Welcome everyone for the class on cardiology. Cardiology will be dealt in two parts. Part one is today, part two will be the next class. All right, in part one, we'll be discussing major part of the cardiology. In part two, mainly we'll be discussing the recalls with the congenital heart diseases. To continue with the cardiology, first we need to know or we need to be aware of echo. Echo per se, we do not do complete echo. It is usually done by the technicians or the cardiologist. We mainly concentrate on the point of care ultrasound scan. So we need to be aware of the different images, what we can get of the heart or different views of the heart, what we are aware of, what are the structures, what we are visualizing, what will be the abnormalities when you visualize this. This is extensively used in the emergency department, hence it can be tested in your exams. In the previous dates, it has already been tested in the exams. That's why you need to be aware of point of care ultrasound in perspective of an heart. First thing is the ultrasound machine. Ultrasound machine is available in various size and forms and shapes. Some are as small as a laptop or something which is held in the hand itself, as small as your mobile device. Some are very large and big as seen here in the picture what you are having. You have three kind of probes which are available, which are very important. This is known as linear probe. It is also known as vascular probe. As the name suggests, the main functionality of this is to visualize the arteries and the veins. This is known as curvilinear probe, also known as abdominal probe. It is mainly used to visualize the abdominal organs. This is known as cardiac probe. As the name suggests, it is used to visualize the heart. This is what is required for you to visualize the heart. So now we will be seeing the different views of the heart. When you place this cardiac probe, what we have seen here, this cardiac probe, what you have seen here on your chest in the second intercostal space, left side, just adjacent to the sternum, and the pointer, this is the pointer. Usually there will be a marking that is known as pointer on the probe. If this marking known as pointer is facing towards your right shoulder, so this is the right shoulder, so this is the left shoulder, it is pointing towards the right shoulder, then you call it something known as parasternal long axis view. In this view, you will be visualizing the heart in this manner, where this is right ventricle, this is left ventricle, this is left atria. This usually people get confused. What is this? This is nothing but this is the aorta, what you are seeing. So the wall which comes between the left ventricle and the aorta is the aortic wall, what you're having. This is the mitral wall, what you're having. These are the Purkinje's fibers which are holding this mitral wall together. So you need to be aware of the structures, what you're seeing. This is parasternal long axis view. If you are having a long axis view, there should be a short axis view also. In short axis view, what you do is you keep the probe in the same position. That is in the second intercostal space, left side, just adjacent to the sternum. And the pointer now is facing towards the left side, not towards the right side, towards the left side. If the pointer is facing towards the left side, then you will be visualizing the heart in a cross section. So if this is the heart, then you have cross sectioned it and you are visualizing from the up. When you are visualizing from the up, you will be seeing two ventricles. One is the right ventricle, another one is the left ventricle. All of us are aware that the left ventricle musculature, the muscle mass is quite more, or it is really thick musculature what you are having on the left side compared to that of the right side. So this is the left side what you are having. So this is the right side what you are having. Right side it is thin because it has to pump the blood only to your lungs. Left side it is thick because it has to pump the blood to the entire body. For that reason, you are having this kind of structure. Because of the musculature of the left side, it is round in structure. It causes a little bit compression over the left right ventricle. So it is kind of crescent in shape what you are having. This is the normal way what you're seeing. So this is the left ventricle what you're having. And here is the right ventricle, which is partially seen in this image what we are having here. What has happened here? Here, what you're seeing here is the the left ventricle appears in D shape, the letter D shape, it appears in letter D shape. Why this has happened? Because there is the enlargement of the right ventricle. If right ventricle is acutely enlarged, there will be pressure over the left ventricle, which will cause the flattening of the wall, that is the septal wall of the left ventricle, resulting in a D shape. This D shape is very particularly seen when there is an acute enlargement of the right ventricle, especially when there is a massive pulmonary emboli. So you get an indirect indication of, okay, this patient might be having a massive pulmonary emboli because I'm seeing a D sign on an parasternal short axis view. So that is the importance of looking at the parasternal short axis view. Now we are having a four-chamber view, also known as apical view. As the name suggests, apical. So you're placing the probe on the apex of the beat, that is fifth intercostal space, mid-clavicular line, with the pointer pointing towards the left side, not any shoulder, towards the left side of the patient's body it is pointing towards. When you place it, usually the ultrasound beams will be going in this manner, so you will be visualizing four chambers. That's why the name also, it is also known as four-chamber view or an apical view for this particular reasons. Whenever you are having a four-chamber view, this is what you are visualizing. The structures you need to be aware of once again. This is the right ventricle, what you are visualizing. This is the right atria. This is the left ventricle, what you are visualizing. This is the left atria, what you are visualizing. So you need to be aware of the structures, what you are visualizing. So basically, how many structures have we gone through it, or how many views of the heart have we gone through it? One is parasternal long axis, another one is short axis, another one is four chambers view. Any of these views can be given in the stem of the question and ask you what is the diagnosis. So diagnosis might be depending on the echo findings what you are having. So knowing the echo findings, knowing the views, and knowing the structures what you're seeing in these views is very important for you to score maximum in the cardiology chapter. That's why initial few slides are about the echo scan. Now we are entering into the cardiology, core cardiology, what we are entering into. First, the very important topic is acute coronary syndrome. Acute coronary syndrome itself involves three main things. Okay, it is not a single entity. It covers three main things. One is ST segment myocardial infarction. That means on an ECG, you are seeing an ST segment elevation. It has an criteria which we'll be discussing in coming up slides. Here you're not seeing an ST segment elevation is not seen, but the biomarkers are elevated. The cardiac biomarkers, we call it, especially the troponin I, the high sensitive troponin I, if elevated, but there are no typical ECG changes what we see in ST segment elevation MI, then we call it as a non-ST segment elevation myocardial infarction. The next thing, the third thing, the last thing what is included in the acute coronary syndrome is unstable angina. It's better to understand first what is stable angina, then it becomes easier to understand what is unstable angina. What is stable angina? Stable angina is basically a patient in whom the symptoms are very typical. So symptoms are typical, but ECG is normal. So this is normal ECG, plus the biomarkers are also normal. So this symptom, this altogether is known as stable angina. What is the typical symptom? Typical symptom is on exertion, the symptoms comes up, not at rest. It's only on the exertion the symptoms comes up. So when I am walking or when I'm climbing steps or when I am basically moving around in the house, I suddenly start getting a chest ache. It is more often heaviness what they describe it than having a pain. It is like a heaviness over the chest, the restaurational heaviness what they're having. They feel like someone is sitting on their chest. And this heaviness, the feeling will be radiating to the left side of the arm, or it might radiate to the left side of the neck. Along with it, there might be some associated symptoms like profuse sweating might be present, some nausea might be present, some shortness of breath might be present. These are all associated symptoms. But these symptoms subside when they take rest. For example, when I walk, the symptoms comes up, but when I take rest for 10-15 minutes, the symptoms disappears. Or the symptoms disappears on taking an GTN spray. This is known as stable angina. For this patient, if you get an ECG done, it will be normal. Biomarkers are also stable. The ECG will be normal, the biomarkers also will be normal, but the symptoms which have appeared in an unstable angina are not very typical. What do you mean by typical? The symptom description will remain the typical itself. The heaviness will be there. It is radiating to the left arm or the neck, the profuse sweating, the nausea, vomiting. Those typical signs and symptoms will remain there. But it is not for the exertion. I'm sitting watching TV and suddenly the symptoms started appearing. So there was no triggering agent. There was no exertion at all involved, but suddenly the symptoms started appearing. That's why it is known as unstable angina. This unstable angina is considered equivalent to a non-ST segment elevation MI. So the treatment remains the same as that of the non-ST segment elevation MI. There are few other anginas what you need to be aware of. The other angina is Prince metal angina. This is mainly because of coronary vasospasm. The cardiac muscle the blood supplies by the coronary artery. When the coronary arteries get constricted for any reason, for example, he has taken a cocaine and suddenly they get signs and symptoms which is very much similar to that of a myocardial infarction because blood supply is compromised. Whenever the blood supply is compromised, the signs and symptoms becomes very much similar to that of a myocardial infarction because the muscle is dying. If you get an ECG done at that point of time, there will be ST segment elevation. But once the coronary vasospasm are resolved, the symptoms will disappear. So if you get an angiography done in this patient, you will not find any blocks at all in this patient because it was because of the coronary vasospasm, not because of atherosclerotic or thrombotic changes in the coronary arteries. Decubitus angina is very typically seen in severe heart failure, that is congestive cardiac failure, or also known as heart failure patients. Because of this severe heart failure will be mainly because of severe coronary heart disease. So whenever they try to lie down flat, at that point of time, they get this pain, very typical angina kind of pain. When they sit up, this appears. That is known as decubitus angina. So these different words you need to be aware of because in the options, they might mention Prince metal angina, decubitus angina. Then it will become easier for you to rule out. I know what is Prince metal angina. This is not because of a coronary pathology. It is because of a coronary vasospasm. Decubitus angina. I know this decubitus angina is seen in the severe heart failure patients. Easier severe heart failure patients. No, I can rule it out in that manner. So you need to be aware of this wording. So it will become easier for you in the examination to rule out the options what they are given. So remember what is Prince metal angina, what is decubitus angina, what is stable angina, what is unstable angina. Now let us enter into myocardial infarction. I'm not talking about an ST segment or a non-ST segment elevation MI. I'm just talking about an myocardial infarction. Yeah, myocardial infarction by definition is where the biomarkers are elevated. The cardiac biomarkers should be elevated. Plus, any one of this following should be present. Symptoms which are very typical as I described previously of an myocardial infarction should be present, or there should be a typical ST wave changes or a new onset LBBB should be present, or in pathological Q waves, significant Q waves should be present, or in renal wall abnormalities seen on an echo scan should be seen, or on an angiography, you should find an thrombus. So any of this following along with an elevated cardiac biomarkers, if present, then we call it as a myocardial infarction. What basically happens in an myocardial infarction? So if this is an myocardial muscle, if you're considering, and this is an coronary artery, what you're considering, if this muscle doesn't get enough of oxygen, at that point of time, this muscle starts dying. That is known as infarction. The infarction can be in any part of the body. This is particularly for myocardium, what I'm talking about. It can be in your bowel. We call it as an mesenteric ischemia. Or it can be in your limbs. Then you call it as an acute limb ischemia. Or so there are various things what you are talking about, various muscles, they have the infarctions which can be going on. So whenever the muscle is dying, the patient has a severe pain because someone is dying, a cell is dying for that particular reason. Because the blood supply compromised to the myocardium can be because of various reasons. Hence, myocardial infarction is divided into type 1 and type 2. In type 1, mainly related to the coronary arteries, what we are talking about. It might be because of a plug which is present in the coronary artery, or it might be rupture, or it might be dissection of the coronary artery. Blood supply to the myocardium can be decreased because of other reasons also, like anemia. The number of RBCs have reduced. So the oxygen carrying capacity of your blood has reduced. So the oxygen supply to the myocardium has reduced. That also can cause myocardial infarction. A severe anemia can lead to a myocardial infarction. Coronary vasospasms because of cocaine can lead to a myocardial infarction. Arrhythmias, where there is a compromise of the coronary blood supply or the demand is not met. Your heart is contracting very fast because of an tachyarrhythmia, for example. At that point of time, the demand of the oxygen the heart muscle requires is quite on the higher side. If your coronary arteries are not able to supply it or meet the demand what the myocardium is having, it will go under infarction or under ischemia. Those are known as type 2. Most of the time in the emergency department, what we encounter is because of the coronary pathology. That's why we consider doing an percutaneous intervention for this patient. In type 2, it is very rarely seen. Most of the time, it might be because of anemia or coronary vasospasms, but you need to be aware of there exists something known as type 2. 99.9% of the time, it is type 1. So in exam, for all practical purpose, it is an type 1 unless and until proven otherwise. Okay, then only you will consider this as type 2 because the chances of this is very, very low. So never consider type 2. Always rule out type 1 myocardial infarction, then only consider an type 2 myocardial infarction. Problem with the definition what we had in the here. This is the myocardial infarction definition what we have. The first line itself says that there should be an elevated cardiac biomarkers, which is not always possible. It is not an acute thing to happen. Usually it takes around 3 hours for the cardiac biomarkers to get elevated. What to do in that time? Do we wait till 3 hours so that the cardiac biomarkers get elevated, then we start intervening? No, absolutely not. Because each second, if not each minute, is very, very important. Every minute goes by, the muscles dies. You may not be able to regain the dead muscle at all. So you need to, as soon as possible, you need to make sure that there is continuous oxygen supply to the myocardium so that the muscle doesn't die. So you need to open up the vessels. You need to open up the coronary arteries as soon as possible. How can you find out much more earlier than waiting for the cardiac biomarkers? By seeing the electrical cardiogram. So by drawing an electrical activity, what is seen in the heart, that is nothing but an ECG, you can come up and make out whether it is an ST segment elevation myocardial infarction. There is a criteria, not just any ST segment elevation is considered as an ST segment myocardial infarction. There is a criteria. If the ST segment elevation is more than 2 mm, that is more than 2 small boxes is present in 2 continuous chest leads, then you call it, or then you can consider it as an ST segment myocardial infarction. In the limb leads, if it is more than 1 mm of ST segment elevation, then also you can consider this as an ST segment elevation myocardial infarction. If there is a new onset, new word is important, a new onset, not a known case of left bundle branch block, a new onset of left bundle branch block is present, then you can also consider it as an ST segment myocardial infarction. Depending on which leads are involved, you can predict which part of the heart is getting infarcted. And at the same point of time, you can predict that which coronary artery is the one which is involved, or which one is the culprit artery where the pathology is present. You can guess it by looking at the ST segment elevation in the ECG. For example, if the ST segment elevation is in lead 1 and 2, it is septum what is involved, or the septum or septal artery basically what is involved. The artery which supplies it is LAD. LAD stands for left anterior descending artery. Anterior wall is involved, particularly when V2, V3, V4, these leads are involved, then we call it as an anterior wall myocardial infarction. Anatomically, anterior part of the heart is involved. Again, the artery most likely will be an LAD, left anterior descending artery. What about the lateral side? This is the most lateral part. Most lateral part is V5, V6. Along with it, 1 and AVL are the lateral parts. So ST segment elevation in V5, V6 are 1 and AVL. Then you need to consider lateral part of the heart is involved. Most of the time, it is the LCX, lateral circumferential artery, what we are talking about. LCX, what we're calling about. This is the artery which is the culprit. If this is not given in the options, then you can select an LAD. Inferior wall. This is the inferior wall what you are having, which represents the inferior part of the heart. So 2, 3 AVF is the inferior part of the heart what you are having. If this is involved, most of the time it is the right coronary artery which is the culprit. If this is not given in the options, then you can select an left circumferential artery as the most likely cause. A new onset LBBB, also considered as an ST segment elevation MI, that means the anterior part, the anatomical equation is the anterior part of the heart is involved. The culprit artery will be an LAD in this patient. What if it is an extensive anterior wall myocardial infarction? Extensive, we call it if lead 1 to V6, it is involved. Multiple leads are involved. So anterior wall is involved as well as the lateral wall is involved. So you call it as an anterior lateral wall myocardial infarction. Okay, so you call it as an anterior lateral myocardial infarction. What if, so this is what I'm talking about. We call it as an anterior lateral myocardial infarction. It is also known as extensive anterior wall myocardial infarction. This both the things means the same. Most of the time, it is the proximal LED which is blocked. It is very rare that a distal LED along with an left circumferential artery is blocked. It is a rare thing. So this option usually will be wrong. The correct artery involvement will be the left anterior descending artery. So if it is an extensive anterior wall MI, or if it is an lateral, sorry, it is an extensive anterior wall MI, or it is an septal wall MI, or it is an anterior wall MI, always consider it is an LAD, including left bundle branch. It is an LAD, which is the culprit artery. So you need to be aware of this algorithm so that you can predict which artery is the culprit one, what is the anatomical location which is present. Let us see a few ECGs. Whenever you are seeing an ECG, do not start looking at one AVR, V1, V4 in that manner. It is time consuming. When you're seeing it, you need to see it in chest list V1, V2, V3, V4. These are the important chest lists what you're looking at. Look them at once. If any ST segment elevation is there, you're considering it as an LAD artery. Then you're looking at the lateral leads. Lateral leads are V5, V6, 1, and AVL, what you're looking at. If there is an ST segment elevation in this leads, you're considering the culprit artery to be and left circumferential artery. The involvement, anatomical area involvement is the lateral surface. If it is the inferior wall which is involved, that is 2, 3, AVF is the inferior wall which is involved, then you need to consider it to be an right circumferential artery as the culprit artery. So you need to see in that manner, 2, 3 AVF together, you need to see 1 AVL, V5 and V6 should be seen together. V1 to V4 should be seen together. So it becomes easier for you to make out which anatomical area is involved and which coronary artery is involved. If you see each leads, it might be quite confusing. So practice yourself from now on when you are seeing the ECGs, practice yourself to look at the ECGs in this manner. Let us see a few of the ECGs and make out what we are seeing here. We are seeing an ST segment elevation in V2, V3, V4 here. So it is an anterior wall myocardial infarction what you are having. Most likely the culprit artery will be an LAD. Next ECG what we are having. We are seeing an ST segment elevation in 1 and AVL, suggestive of an lateral wall myocardial infarction. Most likely the culprit artery will be left circumferential artery in this patient. The next one we are having is an ST segment elevation seen in 1, AVL, V2, V3, V4, V5, V6. So it is the anterior wall which is involved plus the lateral wall it is involved. So it is known as anterior lateral myocardial infarction, also known as extensive anterior wall myocardial infarction. Here, most likely it is the proximal LAD or just simply an LAD which is most commonly involved. Distal LAD plus LCX is very rare, so always pick up the LAD as the right option here. In this patient, what we are seeing, there is an ST segment elevation in 2, 3 AVF. So it is an inferior wall myocardial infarction what the patient is having. Most likely the artery involved is right coronary artery. Whenever you are having an inferior wall myocardial infarction, it can be because of posterior wall involvement or because of an right ventricular involvement. If it is because of an right ventricular involvement, sorry, RV4 will be elevated. That is, ST segment elevation is seen in RV4. What do I mean by RV4 in this patient? RV4 is basically, if you go back here in the chest list, what we are talking about, RV4 is basic. I'm sorry. Yeah, here, this chest list, which is V4, if you replace it from left side and place it over the right side, then we call it as a right-sided V4 chest lid. In an inferior wall myocardial infarction, if you place this lid and you see an ST segment in RV4, then you consider it as an right ventricular involvement. So let us see the ECG what we had and we will consider whether it is a right ventricular involvement or not. Yes, here we are seeing right-sided V4 leads, there is an ST segment elevation. Hence, it is known as, there along with it, there is an ST segment elevation in 2, 3 AVF. So it is an right ventricle which is involved. Let us see on one more ECG. One more ECG here, what we had. This is an inferior wall myocardial infarction, what you are having. Along with it, there is an ST segment elevation seen in V1, V2, V3, sorry, ST segment depression. ST segment depression is seen in V1, V2, and V3 along with ST segment elevation in 2, 3 AVF. So it is an inferior wall myocardial infarction mainly involving the posterior wall. That's how you will differentiate whether an right ventricle is involved or the posterior wall is involved in an inferior wall myocardial infarction. So as I was telling you, so it can be in posterior wall involvement or in right ventricular involvement. Why is it important? It is important because if it is the right ventricle involvement, most of the time they present with an hypotension. This hypotension is because of reduction in preload. If you remember your physiology, what you learned in your primary MRCM primary, what is preload? Preload is basically the venous return, what you are having, but this venous return is not pumped into the lungs at all. So there is reduction in the venous redundant, there is reduction in the preload. Because of that, the patient is having hypotension. To increase the preload, you need to give IV fluids. So whenever it is an inferior wall myocardial infarction and the patient is having low blood pressure, treat it with IV fluids. Do not start on inotropes. That is a takeaway message here. If it is a posterior wall involvement, already I said you there will be ST segment depression in V1, V2, and V3, what you will be typically seeing. So this ECG, as I told you, it is the right ventricle which is involved here. It is an inferior wall myocardial infarction with involvement of the right ventricle. Here, what are we seeing here? Here, what we are seeing here is there is an ST segment depression with tall T waves. ST segment depression with tall T waves, what we are seeing here, this is very typical of D-Venters syndrome. So do not forget D-Venters syndrome. It should be treated equivalent to and STEMI, which we have learned in our ECG class. This is equivalent to STEMI. The next one, what we are seeing is the Valence syndrome. Biphasic T waves are seen in V2 and V3. Biphasic T waves. Biphasic is one is positive deflection, one is negative deflection. If this is the isoelectrical point, that is typically seen here. If it is seen in V2 and V3, we are seeing only two chestlets in Valence syndrome. Then you call it as an Valence syndrome. There's one more variant of Valence syndrome where you will be seeing deep inverted symmetrical T waves in V2 and V3. This is also an Valence syndrome. This is an equivalent to ST segment myocardial infarction. So you need to be treating this as an ST segment myocardial infarction. So D-Venters syndrome, Valence syndrome. D-Venters is because of LAD occlusion. LAD stenosis is seen in Valence syndrome. They will present with typical symptoms itself. It is the anterior wall anatomically which is involved. Do not forget, most likely the culprit artery or culprit artery is LAD, that is left anterior descending artery. So all of this you need to be aware of. These two were covered in the ECG class. I've just repeated here so that you can correlate the things, what you're seeing. So what we're having here in the ECG, what you can see here in the ECG is there is an electrical activity which is happening right before the QRS complex. This is the electrical activity what I'm talking about. It is like a straight line. Why this is a straight line? This is a straight line because the pacing is done by an external device because of an pacemaker. Okay, a pacemaker, the external device, the pacer, the pacemaker, what you call it, is implanted subcutaneously and it paces the heart. SA node is not pacing here. It's the pacemaker which is pacing the heart here. This electrical activity is generated from an electrical device which is external of the heart, doesn't pass through the normal electrical pathway. That's why you are having a broad QRS complex. So this is known as paced rhythm. Okay, so remember, so this is known as paced rhythm. You know now how to pick it up and paced rhythm. What is this, what we are having here? Obviously, there is a broad QRS complex, which is broad, what you can appreciate very clearly. Along with it, you can see the M pattern here. The M pattern also is very clearly seen. So this is an left bundle branch block, what you're having. Whenever you are having a left bundle branch block or an paced rhythm, what you are having, what we discussed previously here, it becomes difficult to interpret and say that these patients are having ST segment myocardial infarction or not. So there is an ST segment elevation here seen. Is it significant? Can I label it as an anterior wall myocardial infarction in this patient? Not sure. What about in a pacemaker rhythm? Similar findings which are seen here. Is this significant? Can I label it as an ST segment myocardial infarction or not? It becomes difficult. For that particular reason, there is a criteria known as Sarbosa's criteria. Sarbosa's criteria is a little bit complicated. That's what is mentioned here. You need not remember this, but you need to remember there is a criteria known as Sarbosa's criteria. So whenever the patient is having a left bundle branch block, that means known case of left bundle branch block. Is a known case of left bundle branch block, has come in with a chest pain. You're not sure whether the CCG changes what you're seeing is because of a left bundle branch block or they are because of myocardial infarction. At that point of time, in that confusion, you use an Sarbosa's criteria. This is the Sarbosa's criteria. You can go through it on your own time. No one remembers it. They always go through this criteria whenever they come across a known case of LBBB or a patient with a pacemaker comes with a chest pain. They use an Sarbosa's criteria. So this criteria needs to be used to know whether the patient is having actually an ST segment elevation myocardial infarction or not. Biomarkers. Biomarkers are basically the cardiac enzymes, what you're talking about. Whenever the muscle is broken down, this cardiac enzyme gets spilled out into the serum and it can be picked up. It usually takes around minimum of 3 hours from the onset of the chest pain to be appearing in the serum. Hence, the test can be picking it up. So there are highly sensitive troponin eyes, which can really pick up and peak as less of a time, like in 3 hours from the onset of the chest pain. 6 to 12 hours is mainly for the trop T, which is kind of outdated nowadays. More and more, they're using high sensitive troponin I. Again, the peaking time depends on the manufacturer of the device. Manufacturer of the investigation and the how sensitive device are you using it. So it differs from hospital to hospital depending on what kind of device are they using it. And usually it remains, once it's elevated, it remains elevated for approximately 7 to 10 days for trop I. For trop T, it remains elevated for approximately up to 2 weeks. So any patient who comes back to the emergency department, for example, he had a myocardial infarction a week back, he comes back. Then which biomarker is preferred? CKMB will be preferred at that point of time because it comes back to the normal values in 3 days itself. So someone who comes back after 3 days, CKMB will be preferred. Otherwise, you may not be able to depend on the TROPI values. There's a trick to be used, which I'll be discussing now. But remember that CKMB is outdated. It is only used if the patient comes back in a week's time after having a myocardial infarction and complains of similar complaints to see whether it's a new myocardial infarction or not. CKMB will be done at that point of time. Trop I and Trop T are the preferred one. More preferred one are high sensitive Trop I. What usually is done is there is a set protocols which are set in different hospitals or different trusts in the NHS, then they follow it. Usually one of the protocols what I'm mentioning here is you get it and drop I value at the time of the presentation itself. For example, he is having ongoing chest pain since last 30 minutes, no ST segment elevation changes are seen. You get a drop I. You wait for 3 hours, then repeat the investigation and compare this value with the second value. If there is increase by 20% of the value, absolute increase in the value of troponin after 3 hours, then you label it as an acute coronary syndrome. That basically you label it as a non-ST segment myocardial infarction for this patient. Okay, that is one of the examples what we are given. There are various other ways they can do it. Sometimes they wait only for 1 hour if they have very high sensitive tropi. Sometimes they might wait for 6 hours, or the initial tropi itself, they wait for the 6 hours and take it because they need not repeat it again. So there are various protocols which are followed in various NHS trusts. So you will follow in your hospital which protocol is being followed. It is preset by the cardiologist before in hand so that there are no doubts. Though troponin I are quite specific for the cardiac infarction, it is not always very specific. It can be seen in various other conditions. Like in myocardial contusions, it can be seen a heart failure, arrhythmias, myocarditis, inflammation of the myocardium, structural heart diseases like aortic stenosis, undergoing an cardiac surgery like a bypass surgery has undergone. Someone who is a CKD patient, renal failure patient, and an acute kidney injury, the patient is severe sepsis, hypertensive emergencies, aortic dissections. Remember, aortic dissections, tropi will be very high, skyrocketingly high, the tropi values will be. A PE patient can have an elevated tropi because there will be increased pressure on the right ventricle, resulting in breakdown of the muscles, resulting in increase in tropi. In an SAH patient, subarachnoid hemorrhages, acute neurological insult is present, pulmonary hypertension, rhabdomyolysis. In these conditions, also tropi can be elevated. Tropi is not very specific for cardiac muscles, but if the symptoms are very typical and he comes and you get a cardiac enzyme done and it is elevated, then you will always consider it as an NSTEMI unless and until proven otherwise. Echo scan. When we discussed about the definition, I said that regional wall abnormality found on an echo scan is also can be considered as an ST segment or a myocardial infarction. What is regional wall motion abnormality? Regional wall motion abnormality, that means you need to have a dynamic image. When you're doing an imaging of the heart, that is when you're doing an echo scan of the heart, you get a real-time image of your heart. In real-time image of the heart, you can see this part of the heart, this part of the heart, this part of the heart, this part of the heart is contracting. This part of the heart is not contracting at all. This region of the heart is not contracting at all, or very minimal contraction is seen. This is known as regional wall motion abnormality. Similarly, here what you can see here is this part of the heart, this part of the heart, and this part of the heart is contracting. This part of the heart, that is this musculature of the heart, is not contracting much at all. Again, this can be labeled as renal wall motion abnormality, which is equivalent to an ST segment myocardial infarction. So you need to get this patient to an PCI as soon as possible. Now, coming to the management of ST segment elevation MI, we totally depend on the NICE guidelines. So whatever I am teaching is absolutely given in the NICE guidelines, not deviating anything from the NICE guidelines. This guidelines includes the things which should be followed by the cardiologist, as well as the emergency physicians, as well as the GP. So we'll be seeing more specifically what is required from the emergency point of view, which is given in the NICE guidelines. So you are having an ST segment myocardial infarction. So every patient who comes with an ST segment myocardial infarction gets an aspirin of 300 mg. It is usually given perorally. If perorally is not possible, you might give you can place an nasogastric tube and place it if the GCS is low. So, but every patient gets an aspirin 300 mg. Then most of the patients will go for reperfusion therapy. Very rarely, if not none, goes to the medical management. When reperfusion therapy is contraindicated, only thing what I can think of is someone who is on palliative care. That means he's already a known case of CA stage 4. He's about to die in few days. For that patient, doing a reperfusion therapy doesn't make sense. That patient goes to the medical management. So this is the medical management, basically blood thinning agents, what we are giving it here. Ticagrelol and aspirin, if there is no high risk for bleeding. If there is a high risk for bleeding, clopidogrel and aspirin or aspirin alone will be giving, depending on the patient. Reperfusion therapy. There are two options for reperfusion therapy. One option is getting an angiography done. That is basically putting a dye in your coronary arteries, looking where is the block is, opening the block and placing a stent. That is angiography followed by angioplasty, what we call it. So angiography followed by angioplasty is one of the options. Another option is fibrinolysis. That is giving an agent, a drug basically, which can break down the clot what is present. In common terms, in a layman terms, we call it as a clot buster. So we are giving a special drug which bursts your clot. That's what we'll be explaining in a layman term to the patient relatives before we give this fibrinolysis. But it is always preferred to get an angiography and angioplasty done over an fibrinolysis. Angiography and angioplasty should always and always be done. When it should be done? If a patient presents within 12 hours of the onset of the chest pain, and you can get an PCI done, that is percutaneous intervention, that is an angiography done within 120 minutes. Do not get confused. It is 120 minutes, not 90 minutes. Those are US guidelines, USA guidelines. You are talking about UK guidelines. In UK, it is 120 minutes. So the patient chest pain should have been in last 12 hours. For example, 6 hours back, I had chest pain. Now I don't have doctor. But on ECG, you have an ST segment elevation MI. Then you will immediately shift this patient to the cardiac cath lab within 120 minutes. If within 120 minutes, if it is not possible, then you go ahead and do an fibrinolysis, also known as thrombolysis. You also consider getting an angiography done in patients who are presented after 12 hours. So my chest pain started like yesterday. So it's been more than, we'll consider more than 20 hours it is now. But still there is ongoing chest pain. That means the muscle is still alive. The muscle is still dying. Okay, a dying muscle only can have the pain. A muscle which is already dead cannot have any pain at all. Or the patient is having a cardiogenic shock. For all practical reasons, for you, the cardiogenic shock will be systolic blood pressure less than 90. If present, these patients are also considered for angiography and angioplasty. Okay. Now coming to the fibrinolysis, you're not able to get it done within 120 minutes. At that point of time, you will do an thrombolysis, also known as fibrinolysis. Preferred agents are multiple. Tenecteplase is very commonly used because it's just an push what we are given. Altiplase is used, but it needs to be used in an infusion manner. So there are various thrombolytic agents which are available. You will be using according to the local protocols. After you thrombolyze, or during the thrombolysis itself, you give fondaparinux to be given at the same time when you start the thrombolysis. After you completed the thrombolysis, wait for the 60 minutes, repeat an ECG and see. If the ECG changes have resolved, so you manage that patient in your hospital itself, where cath lab might not be available. That's why you're not able to shift within 120 minutes. Or you done an ECG, but the changes are not resolved. Still, you see an ST segment elevation. For example, it's anterior wall MI. ST segment elevation was seen in V2, V3, V4. Still, the ST segment elevations are present in V2, V3, and V4. At that point of time, what you will be doing? At that point of time, you shouldn't repeat the thrombolysis. You shouldn't give one more dose of tenecteplase. You need to shift to the nearest hospital as soon as possible. If it takes more than 120 minutes, also it is fine. You will be shifting this patient to the nearest hospital as soon as possible. Along with it, we give few blood thinning agents or antiplatelet drugs which are given, which are not very important. You can go through it, but usually it is not tested in the examinations. The parameters which are tested is everyone gets an aspirin. That parameter is tested. Why everyone gets an aspirin? Multiple research, large studies have shown that it reduces morbidity and mortality. For that reason, aspirin is given to everyone. Next thing they will ask is whether you will get an angiography done or fibrinolysis done. When you will get an angiography done, within what time? That is within 120 minutes. When you will get it done? Either if it presents within 12 hours, or if there is ongoing chest pain, or is the patient having an systolic blood pressure less than 90, then you will go ahead with an angiography. Fibrinolysis, if those criteria are 120 minutes, you are not able to get an PCI done. At that point of time, you will get an thrombolysis done. Soon after thrombolysis, you will wait for 60 minutes, repeat an ECG. If the repeat ECG shows ST segment elevation are still persistent, then you'll shift to the nearest cath lab as soon as possible to get an immediate angiography done. If the ST segment, those are the ECG changes are resolved, then you'll continue managing the patient in your same hospital, then plan it on a different date to shift it to a cath lab, or your cath lab might be ready at that point of time. At that point of time, you might get an PCI done. That is a more planned, that care will be taken care by the cardiologist. Thrombolysis. Thrombolysis is a clot busting drug which cannot be given to everyone. There are contraindications. Most of the time, there will be a checklist for contraindications. We go through the checklist and mark it. For example, is a known case of any coagulation like an hemophilia patient is there? No. Recent any hemorrhages or significant trauma, including dental instructions? No. Any hemorrhagic strokes? No. Any ischemic strokes in past 6 months? No. Any CNS damage, that is basically any bleed or traumatic bleed or aneurysm or any tumors of the brain, intracranial surgeries in last 3 weeks, severe uncontrolled hypertension, anything which is suggestive of pericarditis or recent pericarditis or endocarditis, acute pulmonary diseases, any aortic dissections, any ulcers which are active, any GI bleed in last 4 weeks. And these are the relative contraindications. Usually we do not care much about the relative contraindications. The absolute contraindications which are important. Till now, they are not tested on absolute contraindications, but they can test you on absolute contraindications you need to be aware of. Till now, they are not tested, I feel, mainly because we use a checklist. No one can remember everything as given here in the slide. So they use a checklist. I use a checklist and go through the checklist. It becomes much more easier than recalling each one of the things, because there are more than 10 things what I need to recall. In that pressure, I may not be able to recall all the 10 things. I miss one thing, the patient might be having the same thing, and it might be a disaster. For that particular reason, we usually have a checklist before we do a thrombolysis. That might be the reason they have not tested for the absolute contraindication, but roughly you can see anything which increases the risk of bleeding is an absolute contraindication in these patients, including the CNS. CNS is the tricky part. So anything or any insult to the CNS, that is the central nervous system, especially the brain, like an aneurysm, like an tumor, even an ischemic stroke in the last 6 months, or an hemorrhagic stroke in any part of the life he is having, is an absolute contraindications. What do you need to remember or take away from this slide? What do you need to have? Now we are going into the management of non-ST segment elevation MI. As I told you previously, unstable angina is also treated or considered similar to that of the non-ST segment elevation MI. So what is the treatment? Everyone gets an aspirin, like in STEMI. Along with it, they get an fondaparinux. Unless there is a high risk for bleeding or immediate angiography, you're getting it done. These are the two contraindications for fondaparinux, basically. Otherwise, we tend to give a fondaparinux. Once this is given, we usually admit the patient. Okay, we admit the patient, usually under the cardiologist. The cardiologist gets an GRACE scoring done. It's a complicated scoring. Multiple parameters are present in the GRACE scoring. So usually we use a mobile device to calculate a GRACE scoring, or there might be a chart which we use to calculate the GRACE scoring. So you need not remember what is GRACE scoring, what are the components of GRACE scoring. Is not important from exam point of view. This GRACE scoring, if it is a low risk, they treat it with antiplatelets. Again, you need not remember it, not very important. If it is an intermediate or higher risk and the patient is stable, you plan to get an angiography done within next 72 hours. Again, more taken care by the cardiologist. But the important point here, what you need to remember is the unstable patients. Any unstable patients who is having a non-ST segment elevation MI needs to get an immediate angiography done. So what is the takeaway message from this slide? The takeaway message from this slide is anyone who is having a non-ST segment myocardial infarction, we need to first see whether the patient is stable or unstable. Okay, this is very important for you to see. If the patient is unstable, when do I call it a patient as an unstable? If the systolic blood pressure is less than 90. This patient is having a systolic blood pressure less than 90 and having a non-ST segment elevation MI. This patient, I will be giving aspirin and activate the cath lab and shift for the cath lab within 120 minutes to get an PCI done. If the patient is stable, then I'll be giving an aspirin for this patient. Along with it, aspirin, I'll be giving an fondaparinux. That's all you need to remember from this slide. Okay, remember this. Most of them get confused here. GRACE score, after doing GRACE score, only we can see whether the patient is unstable. No, not required. If the patient is unstable, automatically you can just consider this GRACE score will be high. Definitely it will be high if the patient is unstable. So from emergency department itself, you need to shift this unstable patient to the cath lab. The cardiologist will be unhappy if you just give aspirin and fondaparinux and admit under them saying it's an NSTEMI to an unstable patient. He'll say he's an unstable patient, needs to have an immediate angiography done. Shift to the cath lab. Do not give fondaparinux because it is a contraindication if you're getting an immediate angiography done. So I keep saying here, if you can see here, high risk for bleeding. And if you see in the previous slide, also I mentioned that there is a high risk for bleeding, what I was talking about. Sorry. I'm sorry. This previous slide also I was talking about, and I was talking about high risk of bleeding here also. So whenever I mention a high risk of bleeding, what do I mean by high risk of bleeding? You need to do a scoring for high risk of bleeding, which is known as orbit score. Okay, orbit itself can be taken as pneumonic, older age, more than 65 years. Anemia, it depends male or female, depending on the normal range of the lab values. So anemia, depending on the normal values of the lab value. Bleeding, that is GI bleed or intracranial bleed or an hemorrhagic stroke. Insulin, sorry, insufficient kidney function, I stands for. That is nothing but an acute kidney injury or an chronic kidney injury where the GFR is less than 60. Or he is on treatment with a platelet. So you get this scoring done where older age gets 1, anemia gets 2, bleeding gets 2, and 1 for acute kidney injuries or an CKD patient. Treatment with antiplatelet gets 1. Then you get this score, high risk, whenever it is, the score will be 4 or more than 4. Then you will consider this patient as a high risk of bleeding and you change the treatment protocol as mentioned previously. So you need to remember the orbit score, which is important. At the same point of time, remember that Has-Blood score was used previously. It is no more recommended. Almost it's been 2-3 years since we have stopped following the Has-Blood. According to the NICE guideline, they recommend you to follow the orbit. So if you remember the orbit score, that should be sufficient. Whenever I mention high risk of bleeding, it is depending on the orbit score. Depending on the orbit score, if it is a high risk of bleeding, then you consider, okay, changing of the treatment protocol. What are the possible complications of an myocardial infarction? What you need to be aware of? Pulmonary edema. Pulmonary edema is one of the most commonest complications of an anterior wall or extensive anterior wall or anterior lateral wall myocardial infarction. Okay, so pulmonary edema can be seen. Usually, pulmonary edema is nothing but an heart failure you are having. You treat it with furosemide if the blood pressure is on the higher side, and if the blood pressure is on the lower side, you might have to start on the end. Sorry, if the blood pressure is very much on the higher side, NTG might be started. The treatment of the heart failure we'll be discussing in coming up slides. Cardiogenic shock. The blood pressure might be less than 90 in these individuals. Cardiogenic shock might be because of two valves involvement, anterior wall myocardial infarction. Whenever there is an anterior wall myocardial infarction and the systolic blood pressure is less than 90, start on inotropes. Do not give this patient fluids because, as I said, your anterior wall involvement are prone for pulmonary edema. But what is pulmonary edema? Accumulation of fluids in the lungs. If you give more fluids, he might have, along with the cardiogenic shock, he will have a pulmonary edema also. So whenever there is an anterior wall MI and the blood pressure is less than 90, start on inotropes. Do not give IV fluids. The other reason for cardiogenic shock, that is the low blood pressure, is mainly because of right ventricular failure. That is nothing but inferior wall myocardial infarction. When the systolic blood pressure is less than 90 in an inferior wall myocardial infarction, give them IV fluids. That's what you need to remember. Do not get confused. Mitral regurgitation is mainly seen because of the rupture of this chordae tympani. If they get ruptured or papillary muscles get ruptured, you might have mitral regurgitation. You need to refer to the cardiac surgeons. You cannot do much in the emergency department. Similarly, infarction of the wall of the ventricle can result in rupture of this because they have become quite thin. This is ventricular septal rupture might be present, or a complete cardiac free wall rupture might be present. Then you just refer them to the cardiothoracic surgeons. You cannot do much in the emergency department. What about arrhythmias? Yes, any part of the heart which is infarcted can generate its own electrical activities, can lead to tachyarrhythmias. These tachyarrhythmias mainly are ventricular inversion. Depending on what kind of arrhythmia and the stability of the patient, we'll be treating it. And most of the time, these arrhythmias are seen in an anterior wall myocardial infarction. Most common arrhythmias are seen of VT, followed by VF. Okay, what you need to remember. Supraventricular arrhythmias also seen, but very rarely seen, do not. Conduction defects. Conduction defects means SA node should be involved. SA node is involved if the myocardial infarction, that is basically the part of the heart, is the right side of the heart which is involved, because SA node is present in the right atrium. If the right side of the heart is involved, which is commonly seen in inferior wall myocardial infarction, conduction defects are seen. So anterior wall myocardial infarction, pulmonary edema, and arrhythmias are very common. So anterior wall myocardial infarction, you are having two things are very common. One is pulmonary edema, that is accumulation of the fluid in the lungs. The next thing is the arrhythmias. The arrhythmias which are commonly seen are VT and VF. What if it is an inferior wall myocardial infarction? Two main complications what you're seeing is the blocks. Someone who is having a chest pain and has to come with a block, think of an inferior wall myocardial infarction because the SA node comes in the right atrium. Or it might lead to an hypotension, this patient's. This hypotension is treated with IV fluids. Do not forget, the hypotension is because of the anterior wall myocardial infarction. You're treating with inotropes. Do not forget those parameters, which are very important. Next one is heart score. Heart score is very important. Every alternate diet, a question appears from an heart score. Why heart score is so important? There are plenty of patients who presents with chest pain. Not every patient who presents with a chest pain is having an heart attack, is having a myocardial infarction. So how to know, how to segregate if someone presents with an vague chest pain, he says, I'm having some chest pain on the right side, no breathing difficulty, young fellow, no comorbidities. What should be done for those patients? That's when we do some scoring known as heart score. Okay, heart itself is a mnemonic. That's why it is known as heart score, where H stands for history, E stands for ECG, A stands for age, R stands for risk factor, T stands for troponin values. Okay, this you need to be aware of. If history is very suspicious, 2 points, moderate history or slightly suspicious, 0. ECG ST segment deviations are present, or non-specific repolarization changes, some LBBB or some LVH or some digoxin-related ECG changes are present, or completely normal is present. Depending on that, you will be scoring again. Depending on the age, if the age is more than 65 or between 45 to 65 or less than 45, again, you will be scoring accordingly. But in exams, it is heavily tested on the risk factors. What are the risk factors what we are looking out for? Risk factors, for example, it can be hypertension, high cholesterol levels, hypercholesterolemia, what we call it, known case of diabetes, obese patient if the BMI is more than 30, smoker who is a current smoker or who are smoking cessation, he might say, whenever you ask in patient, no, I stopped smoking. When did you stop? A month back, 2 months back. If he has stopped smoking within last 3 months, again, it is considered as an risk factor. If he has stopped smoking more than 3 months back, for example, it has been 6 months, it has been 4 years since I stopped smoking, then that is not considered as a risk factor. Positive family history of blood-related sibling or father, mother who had an coronary artery disease when their age was less than 65 years. That is before 65, less than 65 years age group. Then you consider it as a positive family history. Otherwise, you'll not consider. People tend to forget on the age. So remember the age. So, atherosclerotic disease, anything which involves any artery where there is an plug is present, that is an atherosclerotic change is present in the artery. For example, myocardial infarction, previous history of PCI, CABG, or an stroke is present, or any peripheral artery disease is present. Then again, you will consider it. Sometimes what they give is, they give all the options and they mention it as a stroke. One option will be hypertension, hypercholesterolemia, diabetes, obesity, and the fifth option is stroke. If the situation is like this, then we recommend you to choose the stroke, because stroke can be an hemorrhagic stroke. It is not always an infarct what the patient is having. At this point of time, we recommend you to select the stroke. Otherwise, do not select the stroke if some other option is present. For example, family history of sudden family history of atherosclerotic disease is present in a father who is age 70 years. So that is not a high risk factor. So that will you selected over and stroke, because stroke can be an infarct also. That differentiation you need to do it looking at the options what are available. One more thing what you need to remember is, if you're having two risk factors, okay, sorry, if you're having three risk factors, for example, hypertension, hypercholesterol, and diabetes, scored as 2. 1 to 2 risk factors, 1. Okay. The tricky part here is, if you're having only an atherosclerotic disease, or one of the risk factors is atherosclerotic disease, directly they get 2 points. That's why I mentioned here, or atherosclerotic disease. For example, he is a known case of peripheral vascular disease and doesn't have hypertension, hypercholesteremia, or diabetes, or smoking, or obesity. Still, he gets 2 points because atherosclerotic disease itself is considered as a very high risk factor. That's why he gets 2 points directly. Rest of the things carries only 1 point, 1 point, 1 point, are considered as in one risk factor, one risk factor, one risk factor. Depending on this hard score, what you are getting it. If it is a low score, then you usually discharge. If it is 4 to 6, you admit and further evaluate. That is basically troponin I, serial ECG is what you'll be getting it done. If it is 7 to 10, which is very high scoring, then you obviously you need to think of this patient might require an angiography. This patient might be unstable here. That's what you need to consider. It might be a non-ST segment elevation MI, who requires a non-ST segment elevation MI, and unstable patient requiring an angiography. One you need to consider if the score is on the very much higher side. Give special concentration on the risk factors which are heavily tested in the exams. Every alternate diet which comes in the last diet, they're not asking about the hard score. So I'm expecting hard score will be tested in your diet. So do not forget to concentrate and read about the hard score in your for your exams, especially the risk factors. Before I enter into the myocardial pericarditis, anyone has any questions, you are free to ask me. Anyone has any questions, please ask me. Anyone has any questions? You can type in the box, that is the meeting chat, what is present in the Zoom. Please type it there, so I'll read and answer your questions. All right. We'll enter into the next part. Till now, what we are talking about was about acute coronary disease or acute coronary syndrome, ACS, what we call it. Now we are going into the different part of the cardiology, where we are studying about the inflammation. If the innermost layer of the heart is inflamed, it is known as endocarditis. Okay, endocarditis. It might be infective endocarditis. Most of the time it is because of the infection. So most of the time we'll label it as an infective endocarditis. If the middle layer, where maximum amount of muscle is present. It is known as myocardium. If this is inflamed, then you call it as a myocarditis. Okay, carditis. This is basically suggestive of an inflammation. The outermost lining is of two layers. One is the inner layer known as visceral pericardium. Another one is outer layer known as parietal pericardium. And between these two layers, there is a fluid. Okay, parietal fluid, what we call it, is basically this fluid is present to restrict the friction what you are having. So reduce the friction you are having this fluid. Okay, this also can get inflamed, known as pericardium, pericarditis. The layer is known as pericardium. This, once there is an inflammation, it is known as pericarditis. So we'll be discussing about pericarditis, myocarditis, endocarditis, each one of this. So you know grossly what we are discussing about. So this is the outermost layer, middle layer, and inner layer. Any inflammation of this is known as itis, what we are discussing. So there will be no confusion. Now, first thing what we are discussing is pericarditis. Most of the time, there is no underlying cause for the pericarditis. It is an idiopathic, there is no underlying cause, but some amount of viral infection will be there. So this inflammation is because of the viral infection, some predisposing viral infection, like a sore throat might be present, some joint pains or some flu-like symptoms this patient had a week back. Now he is having this chest pain. They typically present with a chest pain. This chest pain has a classical description that is known as typical pericarditis chest pain. Whenever you see this patients, you walk into the cubicle where this patient is, he'll be leaning forward. He'll be not lying down and being comfortable on the bed. He'll always be leaning forward because the pain is better on leaning forward. Doctor, I do not want to lie down flat. Why? The chest pain becomes worse. When I lean forward, I feel better. I feel a lot better when I'm leaning forward. That's why they are leaning forward. Along with it, there can be an friction rub can be present. And if they are radiating to your blades of your shoulder, that is basically the trapezius muscle. If they are radiating, it is kind of very specific what they mention it, high degree of specificity what is seen. Though I have not encountered this, but this is what they say it. What you do for the treatment for these patients. NSAID is the mainstay of the treatment. Non-inflammatory antisteroidal, NSAIDs, non-inflammatory drugs, what you are basically giving it. NSAID, this is an inflammation, so non-inflammatory drugs. So NSAIDs works wonders here. If the pain is not subsiding in spite of giving NSAIDs, we tend to add an colchicine. Sometimes cardiologists prefer adding colchicine at the first presentation itself. This was tested in the last diet. So remember, colchicine can be added to an NSAIDs if the symptoms are not reducing. What is Dressler syndrome? Dressler syndrome is a fancy name for an pericarditis which is caused because of a myocardial infarction. So he had a myocardial infarction. Now he is coming back with a chest pain after 2 to 3 weeks. This chest pain is not similar to the myocardial infarction. It's more of a pleuritic chest pain. It is a sharp kind of chest pain, what is describing. He feels a lot better on leaning forward and it is worse on leaning backwards. That is a typical symptoms what they are presenting with. And usually you treat it with a high dose of aspirin for this patient. We tend to avoid NSAIDs in these patients because it can worsen the myocardial infarction what the patient already had. So we tend to give high doses of aspirin in these cases. Do we need to admit all the patients who come with an pericarditis, that is the inflammation of the heart, outermost layer of the heart, if they come, do we need to admit all these patients? No, not required. If the patient is quite young and healthy and doesn't have a high-grade fever and doesn't have any immunocompromised disease, you can actually discharge him on NSAIDs and colchicine. If the patient is having high-grade fever, that means more than 38 degrees, there is significant, that is a large amount of pericardial effusion is present. He's not responding to the NSAIDs. Last week he has presented, you started on NSAIDs, he has come back with a similar complaints, not improving. He's an immunocompromised patient, or it is because of the trauma he's having pericarditis. He's on oral anticoagulants, or he is having myopericarditis. That means along with the pericarditis, the outermost layer, along with this inflammation of the myocardium is also present. Then you admit this patient. Inflammation of the myocardium can be picked up if there is an raised troponin I values. Okay. This oral anticoagulants or any anticoagulants if the patient is on there, why we are worried about this anticoagulants can cause bleeding in the pericardial space and can result in cardiac tamponade. We'll be discussing about cardiac tamponade in coming up slides, but it can cause the cardiac tamponade. For that particular reason, we are worried. We tend to admit this patient so that we can monitor them closely. Are there any specific ECG findings? Yes, absolutely. Yes, there are specific ECG findings which are present. Concave ST segment elevation with PR depressions, what you are seeing. There are two findings which are present here. Two findings. To make it out, you need to be aware what is the isoelectrical point, where the electrical activity of the heart is absolutely nil. That is, after the T wave, before the beginning of the P wave, the point what you are having, this is known as isoelectrical point. Comparing this isoelectrical point, there is an ST segment elevation. Comparing to this isoelectrical point, there is an ST segment depression, which are diffusely seen in most of the chest leads, and it is also seen in limb leads also. This is a very typical classical ECG of an pericarditis. Now enter into the myocarditis. That is the inner muscle which is involved and which is gotten inflamed. Most of the time, they say Chagas disease is a viral infection which has caused. It's very difficult to label it or isolate the organism and label it because of the Chagas disease. But most of the time, there will be a viral prodrome. A predisposing viral infection will be there. So throat viral infection, cough might be present, or there might be flu-like symptoms might be present. And usually he presents with an heart failure. Heart failure means he presents with a shortness of breath. Okay, remember this, a viral infection presenting with a shortness of breath. That is the typical presentation of a myocarditis. It is a very, very difficult diagnosis to do it in actual practice, but in practical, for your exam purpose, a viral prodrome they are given and there is an heart failure which is presented with, look for any other clues are there. ECGs will not be helpful. They're all non-specific changes, so you cannot depend on the ECG at all. Echo findings, global hypokinesia they have given. Yes, that is a proper echo finding. What is global hypokinesia? This is a normal heart. You can see all the muscles are contracting equally. You can see hardly any contraction is seen in the left ventricle here. That means global, the complete left ventricle is inflamed. The myocardium, the musculature of the complete left ventricle is inflamed. That's why it is not able to contract. That's what you are seeing here. Along with it, because the muscle is inflamed, there will be breakdown of the muscle, so the troponin I and CPK will be high. This is one of the causes, other causes than myocardial infarction where troponin I can be seen. What is the treatment? It's just a supportive management. What you can do. Someone, if there's a heart failure, it comes, then heart failure treatment we will be giving. For a viral infection, predisposing viral infection is still persistent, then you'll be treating symptomatically. Most of the viral infections, we do not have any treatment at all except the herpes one. So there is no specific treatment for viral infection, so it has to recover on its own. All these patients gets admitted because myocarditis are prone for heart failure and they can deteriorate at any point of time. So you need to admit these patients. Infective endocarditis, as the name suggests, it is mainly because of an infection. Most of the time, it is the bacterial infection. That's why we label it as an infective endocarditis. Innermost layer are involved. There are few predisposing factors. It is more commonly seen if the patient is having an prosthetic wall. Most of the time, the prosthetic wall is the aorta. So most commonly involved wall is aorta. Because the aorta is involved, you can see an aortic regurgitation in this patient. So a new onset murmur, if present in a patient, then you need to consider infective endocarditis as one of the differential diagnoses. A IV drug abuser. IV drug abusers, they do not practice any sterile procedures, so alcohol swabs and all, they'll not be strapping. So they can infuse the bacteria inside the inside the vein, resulting in endocarditis, because that blood will go to the heart, can implant the bacteria, resulting in infective endocarditis. Any previous history of infective endocarditis is also a high predisposing factor. What are the common organisms? Most of the time, someone who has a native wall doesn't have any prosthetic wall, it's the Staph aureus. If it's an IV drug abuser, also it is a Staph aureus. If there is a prosthetic wall and the placement of prosthetic wall is more than 1 year, then the organism changes. The most common organism becomes viridin, step viridans. After a dental procedure, he had an infective endocarditis. Then strep viridans, what becomes a more common one. Okay, this data is taken from RCM Learning, which was published on 18/7/2022. So holds good, nothing new has come up. So this literature holds good, so do not get confused. What is the clinical features what they present with? New onset murmur, that is an aortic regurgitation, can be seen. We'll be talking about murmurs in coming up slides more, but a new murmur is seen in this individual. Because it is an infection, there can be a fever also which is present. Because of fever, poor appetite and weight loss, kind of a non-specific symptoms. Arthropathies, joint pains, kind of non-specific symptoms. Specific symptoms, ocular nodules can be seen. Rod spots can be seen. These are the spots seen on the retina, which are known as rod spots. Janvi lesions, these are also seen on the hands. Sphincter hemorrhages, what are seeing on the nail beds here. Because this infections are there here, this can embolize. These are in the heart. This can embolize. This is the bacteria. They can embolize. They can act like in thrombus. They're not thrombus, but they can act like in thrombus and block any of your arteries if this is pushed into your arteries and cause an stroke, an infarction. So anywhere it can cause a stroke in brain, any part of the blood supply of the brain can be involved and resulting in a stroke. They can resulting in a pulmonary emboli also. They can result in a digital ischemia also. Sometimes splenic infarction can result in splenomegaly also. Okay, these are the things because emboli, obstruction. Initially, the spleen enlarges, then it goes self-infarction, then it reduces in the size. So these are the clinical features what you'll be seeing it. You can always suspect an infective endocarditis in the emergency department. You cannot diagnose an infective endocarditis in the emergency department because the diagnosis mainly depends on the Duke's criteria. Duke's criteria includes blood cultures. Blood cultures needs minimum 48 hours to be positive and make a result. So what we do in emergency department is, depending on the signs and symptoms, what has the patient has presented with, we suspect an infective endocarditis and send 3 samples of blood culture which are 1 hour apart and start them on the antibiotics. That is what is very important. Along with it, you might get an echo scan done. Echo scan is very helpful because you can see the vegetations. You can see the vegetations. This vegetations, what you're seeing, this vegetations can be seen on the echo scan. So what you are seeing here is the vegetations, what you are seeing. Very difficult to pick it up, but these are the vegetations. These are the vegetations, what you are seeing. This can be picked up by the cardiologist or the technicians who are doing the echo scan on a regular basis. But this is out of scope for an emergency physician to pick it up because it is not very easy unless there is an obvious vegetation is present and it's a large one, then you can easily pick it up. What does the Duke criteria say for the diagnosis purpose? It says that 2 major criteria should be satisfied. That means a blood culture, 2 positive blood cultures should be there, or persistent positive blood culture for same organisms 12 hours apart or 3 hours apart should be present, or an endocardial involvement demonstrated on an echo scan. That is the vegetation seen on the echo scan. Or there might be 1 major criteria and 3 minor criteria like fever, predisposing heart conditions like an prosthetic wall is present, or IV drug abuser is there, or previous history of an infective endocarditis is present. 1 vascular phenomena, what we have discussed here, like a Janvi lesion or sphincter hemorrhage is present. 1 immunological phenomena is also considered as a minor criteria. Immunological phenomena like an rod spots, what we consider, like an ocular nodules, what we consider, or there is a positive culture which doesn't meet the major criteria. They're not the typical organisms which doesn't meet the major criteria or minor criteria. This is again not tested till now in the exam. The main reason what I think is because these reports are not available. We do not have the culture reports available. How can we make a diagnosis in the emergency department without having the culture reports? These are available only after the admission. So it is more important for an acute medicine physician or the cardiologist rather than for an emergency physician. For the emergency physicians, you sending the cultures, starting on the antibiotics, suspecting it is an infective endocarditis, depending on the presentation, is very important for you. At the same point of time, let us discuss about pericardial effusion and cardiac tamponade. Cardiac tamponade, usually they present with a classical triad, which we'll be discussing in our trauma class. But here, raised JVP, that is distended neck vessels, will be present. Along with it, the patient's systolic blood pressure will be less than 90. Along with it, the patient will be having muffled heart sounds. Muffled means you're not able to clearly hear the heart sounds because there is large amount of fluid around the heart. So hardly the sound is not conducted through the fluid very well. That will result in muffled heart sound. You'll not be able to hear this heart sound properly. So if this classical triad is present, then you can label them as an cardiac tamponade. Pericardial effusion is different from cardiac tamponade. What is cardiac tamponade? What is pericardial effusion? Both has the fluid in the pericardial space. So a pericardial effusion which causes hemodynamic compromise. That means the systolic blood pressure being less than 90. Then you consider it as a cardiac tamponade. So always remember that pericardial effusion is not same as cardiac tamponade. Pericardial effusion can be up to 1.5 liters of fluid can get accumulated in your pericardial space without causing any compression on your heart at all. Okay, if the fluid gets acutely accumulated, that's when the problem arises. That's when you need to intervene. On an X-ray, if you get it done, pericardial effusion appears like this, a large pericardial effusion. It appears like a globular heart like this. It appears like that. A typical heart will appear in this manner. At the same point of time, it is enlarged. It is more than 50% of the chest-to-chest diameter, what we have learned in our first class. What are the echo findings, what you will be seeing? Echo findings, obviously free fluid around the heart. How do we pick it up free fluid around the heart? This is the echo image. This is the heart, what you are having. Around the heart, what you are seeing is the black color. So this black color, what you are seeing is the free fluid. Because blood is fluid, it is picked up as black in color. So it will appear black on the image, what you are having. At the same point of time, if it is a dynamic image you are having, the heart will be swinging around. What you can see here is the heart is swinging. Why it is? It is moving around the fluid. It is fluid which is there, so it can move around. If you place a plastic ball in an mug full of water, if you're moving around the bottle, what you are having, the ball also moves around. So it is known as swinging effect. So the heart moves around the free fluid which is present. This is known as swinging heart. Swinging heart and pericardial effusion can be seen. But what is the diagnostic? This can also be seen this can also be seen in pericardial effusion. It is not specific for cardiac tamponade. What is specific for cardiac tamponade? This was tested in FRCM exam. Okay, it was not tested in an RCAM for MRCM SBA exam. It was an FRCM consultant level they are tested. When you do an echo scan, if there is an RV and RA collapsed during the diastole, there is a collapse of RV especially and RA especially, that is right side of the heart. If it is collapsed, then you consider this as an cardiac tamponade. Okay, that's how you find it on an echo scan, whether this is an cardiac tamponade. So echo finding for an cardiac tamponade is diastolic collapse of the right side of the heart, that is right ventricle and right atria. In severe diseases, left side of the heart also might be collapsed, but initially always the right side is collapsed because the musculature is quite thin, so it collapses. Once the pressure increases in the pericardial space, first thing collapses is right ventricle and right atria, followed by the left side of the heart. Any specific changes which are very characteristic of the pericardial effusion? Yes, there are specific changes. Because fluid is accumulated around the heart, the electricity which is passing through the fluid is hampered. So the amplitude reduces. So the amplitude, what you can see, is very small. So reduced amplitude of the QRS complex, what you can see. At the same point of time, I said that heart is swinging in. So sometimes it will be closer to the anterior wall of your chest. Sometimes it will be away from the anterior wall of the chest. Whenever it is closer to the anterior wall of the chest, the amplitude of the QRS complex is on the slightly on the higher side. When it is away from the wall of the chest, the amplitude of the QRS complex reduces. So it alternates because of the swinging effects. So it alternates. This is known as electrical alterance. Electrical alterance is very much specific for cardiac tamponade or from pericardial effusion. You cannot differentiate on the ECG whether it is in cardiac tamponade or pericardial effusion, but it is very specific electrical alterance that is varying varying amplitude of QRS complex from beat to beat is very specific for an pericardial effusion. It is seen because of swinging of the heart. How do you treat it? Aspirate out the fluid what is present. How to do in pericardiocentesis we'll be learning in the procedures chapter. When an pericardiocentesis is contraindicated, it is contraindicated if the pericardial effusion is because of aortic dissection or because of an post-infarction rupture of the free wall, that is ventricular free wall rupture. If this is an heart and this is got ruptured here because of myocardial infarction, this heart became thin and it got ruptured. Okay, or it might be because of an aortic dissection. What happens here? Why pericardiocentesis is contraindicated in this situations? Consider this as an heart, very badly drawn. This as an aorta. There is a dissection here, so the blood is seeking in and it has accumulated around the heart in the pericardial space here. So continuously the blood is getting accumulated here. In this patient, if you keep on aspirating, the blood will keep on accumulating and eventually he will die. So there is no point in doing an pericardiocentesis in this patient. Same thing holds good if there is a rupture of the free wall itself. If you continuously aspirate, you will keep on aspirating. There will be no stop for it. At least if you leave it as such, it can cause a tampon effect here and might form a clot and stop the bleeding what is present. They might form a clot here and stop the bleeding what is present. What is actually required for this patient? You need to refer to the cardiothoracic surgeons. These cardiothoracic surgeons will do an open heart surgery, see where is the defect and fix the defect. Most of the time, free wall rupture is very easily fixed. It's like an like in glue. The device is available. It's like a bandage what you are having, literally like a bandage. They will be placing it over it and it is fixed. That's how they fix and free wall ventricular ruptures. To summarize what we have learned, whenever there is an viral infection, predisposing viral infection, and they present with an heart failure, consider it as an myocarditis in your exam. A viral infection and a typical pericarditis chest pain that is better on leaning forward, worse on lying backwards, consider it as an pericarditis. A viral infection with an atypical chest pain, if it is present, consider it as an myocarditis. What is atypical chest pain? That means which is not suggestive of an pericarditis. Then you consider as an still as an myocarditis, not an pericarditis. So to consider as an pericarditis, always there should be a typical chest pain. You need to remember. Anyone who is an IV drug abuser or has a prosthetic wall has presented to the emergency department with a pneumoma. Okay, murmur can be anything depending on the wall which is involved. So a new onset murmur is present. Then consider it to be an infective endocarditis. So this summarizes basically how to pick up the diagnosis. Then we know the treatment. For example, infective endocarditis, IV antibiotics are required. Pericarditis, you are usually treating with NSAIDs plus colchicine, what you are giving it. Myocarditis, you're basically treating it symptomatically. Most of the time, it is the heart failure. So heart failure treatment, what you will be giving. Anyone has any doubts, you can ask me before we enter into the atrial fibrillations. Can pericarditis can raise the troponin I? Usually troponin I is not raised in pericarditis, rarely seen, but it can cause. Okay, it can cause, especially the visceral pericardium, pericarditis is involved. It can cause tropi, elevated tropi. But whenever there is an elevated tropi along with an typical features of pericarditis with an elevated tropi, we consider there might be an myocardium also which is inflamed. So we call it as a myopericarditis. Should we give IV fluids in pure inferior wall MI like right ventricular infarct? Yes. If the patient is hypotensive, yes, you are treating the hypotension with an IV fluids. If your question is it absolutely, is it as a routine required to give IV fluids if the patient is not hypotensive also? No, it is not required to give as a routine. You are intervening only if the patient is hypotensive by giving IV fluids. Otherwise, routinely it is not required. Hard score special risk factors, choose option, some queries. I'm not sure. You need to be more precise about that one. I cannot understand that part. ECG changes in pericarditis, you see diffuse ST segment elevation. Most of the chest leads and limb leads, you see ST segment elevation along with PR depression. These are the two classical findings what you are seeing in pericarditis. Organisms, what I mentioned is the same one. What you need to remember, do not get confused. What I mentioned is the one what you need to stick for. Getting into the atrial fibrillation. Atrial fibrillation, we have learned what is atrial fibrillation. So the electrical activity is generated from the atria. So it is one of the supraventricular origin of the rhythm what is present here. There are no P waves or no appreciable P waves which are present. So no absolute P waves are present in this patient. Along with it, the rhythm is irregular. Then you label it as an atrial fibrillation. What are the causes for atrial fibrillation? There are various causes for the atrial fibrillation. It can be an idiopathic cause. Yeah, but there might be an underlying cause. The underlying causes can be remembered with a mnemonic known as PIRATES, where P stands for pulmonary emboli, I stands for ischemia, myocardial ischemia I'm talking about. R stands for respiratory diseases. It can be any infections like a pneumonia, it can be, or ARDS can be. Atrial enlargements. Enlargements might be because of a tumor like in myxoma. Thyroid disorders, especially hyperthyroidism. Binge drinking can cause atrial fibrillation. A sepsis or a sleep apnea also can predispose to an atrial fibrillation. Various definitions of atrial fibrillation you need to be aware of. Like a new onset atrial fibrillation. What is new onset? As the name suggests, he was never diagnosed with an atrial fibrillation. This is his first presentation and first time you are picked up for that patient that he is having an atrial fibrillation. So it is a new onset atrial fibrillation. These are all are not new onset. They are already known case of atrial fibrillation. What is paroxysmal AF? Paroxysmal AF is the patient will remain in atrial fibrillation in the same irregular rhythm with no P waves. He will remain in the AF and suddenly he will revert back to the sinus rhythm. Then again AF, suddenly he'll revert back into the sinus rhythm. Okay, no intervention is required. On its own, it reverts back to the sinus rhythm and he stays in the sinus rhythm for 1 week and suddenly for 1 hour he has an atrial fibrillation. So paroxysmal AF, we call it. What is persistent AF? Persistent AF is the patient is having an AF persistently unless you intervene and give some medications or give shock, unless you intervene. Once you intervene, it reverts back to the sinus rhythm. So normal sinus rhythm or normal rhythm, it reverts back to. What is permanent atrial fibrillation? Permanent atrial fibrillation is permanent. You intervene, you give some medications, you shock this patient, but still he remains in atrial fibrillation itself. Then we call it as an permanent atrial fibrillation. So either it is a paroxysmal or persistent or permanent atrial fibrillation. They're all are known case of atrial fibrillation. So remember that the doctor who has picked up an atrial fibrillation would have done Chadwa score and would have seen the risk for stroke, and if required, they would have prescribed him on the anticoagulants. Okay, they would have already prescribed him on anticoagulants. You need not add up anything. If it is new onset AF, that's only we are really consider about. That's when we look into the NICE guidelines. So this is the typical ECG of an AF. As I told you, no P waves are seen, so you cannot appreciate any P waves. The rhythm is irregular. This PR interval compared to this PR interval compared to this PR interval is different. That's why the rhythm is irregular. No P wave and irregular rhythm, we label it as an atrial fibrillation. How do we manage an atrial fibrillation? This is a little bit complicated, so I break down into few halves and then we will be proceeding ahead. So first thing what we are seeing is atrial fibrillation if the patient is stable or unstable. If the patient is unstable, then we give him a shock. As simple as that. If the patient is unstable, we give him a shock. We are not thinking about anything. If the patient is hemodynamically stable, next thing what we'll be looking out for. Next thing we'll be looking out for is the heart rate. Okay. Atrial fibrillation, if the heart rate is more than 200 and the QRS complex is broad, if yes, this is what you are seeing. If yes, then what you need to consider, this patient might be having underlying accessory pathways. What are the accessory pathways? What we have learned? Already we have learned about WPW syndrome and we have learned about LGL syndrome. These are accessory pathways. Presence of this accessory pathways will lead to an heart rate more than 200 and broad QRS complexes will be present in these individuals. These individuals are very difficult to be treated. It is recommended that you consult the cardiologist. Usually the cardiologist might advise you to go for an DC cardioversion, that is basically give and shock, or he might advise you to give and flickenide, but always take an advice from the cardiologist. That is the best option or the best step to take. If cardiologist is not given, then shock the patient or the flickenide, which one is given, you can choose one of those options. But most of the time they would have given the cardiologist. Look at the heart rate. Along with the heart rate, there should be broad QRS complex. No, the heart rate is less than 200. At that point of time, what you'll be seeing is the duration. Since when you are having these symptoms? I'm having this symptoms since last 3 days, doctor. Or I had this one thing they might say, I'm having these symptoms continuously since last 3 days. Or they might say, I had this symptom 1 week back, which lasted for 1 hour. Now it has recurred again. That means also you need to consider this is more than 48 hours. Okay. It might be episodic. It may not be continuous. The previous episode, if it is more than 48 hours, then you consider for an rate control. So you're just controlling the rate. The atrial fibrillation rate, you're trying to bring it down below 110. That's what you're trying to do it. Using what? First choice is beta blocker. For some reason, beta blocker is contraindicated, then you can use calcium channel blockers like diltiazem or verapamil can be used. Beta blockers, the preferred beta blocker is metoprolol because it is available in IV form. Nowadays, bisoprolol is more preferred, though it is available in an oral form because it is a long-acting one. No, the onset is less than 48 hours. If the onset is less than 48 hours, rhythm control is what is preferred. Rhythm control can be done using an electrical activity, that is giving a shock, synchronized shock, or you can rhythm control it using an pharmacological, that is basically giving a medication and you can control the rhythm. Control the rhythm means you're converting an AF into a sinus rhythm. How to convert a in the sinus rhythm? You have two options, either by giving a shock or by giving a medications. For giving, which one is preferred? Should I give a shock, doctor, or should I give pharmacological? Give medications. It is easier. If you're giving a shock, you need to do an procedural sedation, then give a shock. You need to take and consent for the shock. So it is a long procedure and you're giving a shock. It is a painful thing. So procedural sedation is required. So it is quite cumbersome to do this in the emergency department. It requires a resuscitation bay and long time of observation. So always a pharmacological rhythm control is preferred over electrical rhythm control. Pharmacological rhythm control, what you need to look out for is there any evidence of structural heart disease? Okay, if the patient is a known case of any structural heart disease or an echo scan, in the stem you need to see he's a known case of ASD, or he's a known case of VSD, or he had an previous myocardial infarction, or an echo scan shows an LV dysfunction where the ejection fraction is around 30%, 40%. At that point of time, amiodarone is preferred. If none of this following is mentioned in your stem of the question, then pick up the flecainide. After this, when you admit, you need to always risk assess for stroke needs to be done. Okay, this is the atrial fibrillation management. One more thing what you need to consider. You need to consider giving therapeutic doses of anticoagulants in anyone who presents with a new onset AF, just offer heparin. Because as I told you, if it is a proximal or a persistent myocardial infarction, sorry, paroxysmal or a persistent AF is present, they would have already evaluated for stroke risk and done a Chadwell score and decided whether anticoagulant is required or not. So you need not break their head for those patients. If it is a new onset atrial fibrillation, previously it was not diagnosed at all. For those patients, you will be treating using an anticoagulant. Basically, stroke prophylaxis, what you are giving it. A known heart failure he faced is not the worsening of the heart failure. It is not the new onset of the heart failure. He's already a known case of heart failure, which is not worsened. It has remained the same. Now he has presented atrial fibrillation. Then digoxin is preferred. Okay, do not follow any algorithm. Just give digoxin in those patients. Digoxin acts wonders. So this is the treatment of atrial fibrillation. Most of the time, what they will be testing in the exam, most of the time they will not be, they might be testing on this hemodynamic stability. They will not be testing on this part. They will be testing on the duration of this part. Less than 48, more than 48 hours. Most of the time, 90% of the time, usually patient presents more than 48 hours, or he'll be known case of AF, or there is recurrent episodes of AF will be there. Then you will be doing an rate control. So most of the time, this is what is tested in the exam, or this is what is tested in the exam. I keep telling Chadwell score. So this is the Chadwell score. What do you need to remember here? What you need to remember is aspirin is no longer given. Okay, aspirin is no longer considered. It is not effective. They think if you want to give directly, they give an anticoagulant. In male patients, if the score is 1, you can consider. So forget this part. This just can consider. Anyone, male or female, who is having score of 2 or more, you give anticoagulant. This is according to the NICE guideline of 2021. What does Chadwa score consist of? It is a mnemonic in itself, where C stands for congestive heart failure, 1 point, hypertension, 1 point, age more than or equal to 75, 2 points. Remember, this is 2 points. Diabetes, 1 point. Stroke, TIA, or thromboembolism, 2 points. Again, vascular diseases, 1 point. Age between 75 to, sorry, age between 65 to 74 years, 1 point. Female sex gets 1 point. Okay, you need to remember the scoring, and you directly give anticoagulants if the score is 2 or more. Again, high risk factors, what we are discussing about, high risk for bleeding, if it's present, then again, the same orbit score we are using it. There is no much changes and there is not much role in this patient. So do not break your head here. Now we are entering into the syncope. Before I enter into the syncope, if someone has any questions, we'll answer your questions before we enter into the syncope. If AF plus heart failure, decoxing is preferred, but is it related any duration, days, limits? No, nothing is related to it. Decoxing is preferred. If it is present within 48 hours or more than 48 hours, doesn't depend on that one. Stable AF patient, should we consider a rate? Stable AF patient, should we consider heart rate 200 and broad QRS complex, both or any other of this following? You need to consider both. Okay, yeah, a patient with an AF who comes with a heart rate more than 200 plus broad QRS complex, then only you are considering that there might be an accessory pathway. It's not one thing. Someone who has only broad QRS complex, someone who has only heart rate more than 200, you will not consider it individually. If hypertension, positive family history, age, obesity, then choose which one. So you are having three risk factors or equal to three risk factors, you'll be getting it 2 points here. So if you're asking which one to be choose between hypertension, positive family history, age, obesity, age is not given. Age is not there as a high risk factor. Okay, if you're asking me for the high risk factor, age is not given. You need to stick for the heart score, what is there. And it is as simple as that, Dr. Niaz. There is nothing much you need to get confused about that one. You need to stick to the heart score, what they have been given. Now we are entering into the syncope part. What is syncope? Syncope is transient loss of consciousness, where they lose their consciousness usually for fraction of a minute, 30 seconds, 15 seconds. So the description will be in seconds, not in minutes, 5 minutes, 10 minutes. That it is more like a collapse than in syncope. For an few seconds, I don't know, doctor, it was 1 minute or 2 minutes, maximum 3 minutes. That isn't syncope. He has lost his complete consciousness. Okay. Then again, he has gained his consciousness completely after 2-3 minutes. There is no confusion at all. Completely, he has gained his consciousness. Then you call it as an syncope. Syncope can be because of various reasons. It can be a reflex syncope. There are various kinds of reflex syncope. Vasovagal syncope, usually there will be trigger agent like an pain or prolonged standing might be present or emotional stress might be present. Carotid sinus syncope. As the name suggests, there is a pressure over the carotid sinus. If there is a pressure over the carotid arteries, a patient can have a syncope. A situational syncope, especially when there is increase in intra-abdominal pressures. Whenever there is an increase in abdominal pressure, there is a valsalva. Whenever happens, like defecation you are doing, or you are micturating, or you are coughing violently. These are all situational reflex syncope. So vasovagal syncope, situational syncope, carotid sinus syncope. There might be an orthostatic hypotension, also known as postural hypotension, means one and the same. Okay. What is the definition of it? If the systolic blood pressure in the lying down or the insisting position compared to the diastolic when standing, if for example, this was 140 and this becomes 110. So the difference is 30. If the difference is anything more than 20, the systolic, or if the difference is more than 10 in the diastolic, then we consider it as an postural hypotension or an orthostatic hypotension. What actually happens? Physiologically, what happens is when the patient is lying down, there is no pulling of the blood in the legs. Okay. Whenever he stands up immediately, from the lying down to the standing up position, when he does it, the blood gets pulled in the lower limbs because of the gravity. At this point of time, there is stimulation of the sympathetic nervous system. Sympathetic nervous system stimulation will increase the total peripheral resistance, which will increase the blood supply to the heart, or basically the venous return will get restored. This this venous return may not be restored if there is something damage to the sympathetic system or if there is decreased in the intravascular volume. Decrease in intravascular volume might be because of the drugs like alcohol you have taken that might cause diuresis or any diuretic medications or any antihypertensive medications. For especially the calcium channel blockers, which causes vasodilatation, it can cause peripheral pooling of the blood can be present or volume depletion. A volume depletion because you're violently vomiting, having a severe diarrhea, or you are having a hemorrhage. It might be a traumatic hemorrhage the patient is having. Orthostatic hypotension can also be because of simple loss of autonomic nervous system, that is sympathetic tone. Might be because of primary failure, which is seen in Parkinson's disease and Lewy body dementia, or it might be secondary autonomic failure because of diabetes, uremia because of kidney failure, or spinal cord injuries. Last thing is the cardiac causes. Because of bradycardia, tachycardia, valvular heart diseases, cardiomyopathies, congenital heart diseases, it can be. Okay, so these are the various causes for an syncope you need to be aware of. That's how you will be evaluating in your practice or in the exam also. That's how you will be thinking whether it is an reflex syncope or it is a cardiac cause or it is a postural hypotension. What has happened in this patient? Postural hypotension will have a typical history. The patient, I was lying down and suddenly I got up and I lost my consciousness. Keeps on happening whenever I from sitting position I stand up. I have dizziness and I lose my consciousness. Reflex, a typical history will be there, some triggering agent will be there, or some pressure on the carotids will be there, or during maturation, during defecation, during coughing, I had this. So situational syncope. Cardiac, these are the cardiac things what we'll be learning. Brady and tachyarrhythmias we'll be learning in the station chapters. Valvular heart disease today, cardiomyopathy today, congenital heart diseases in next class what we'll be learning. Sometimes you may not be able to gain the typical history for in syncope. You may not have any typical history at all. Everything is fine. What to do for this patient? Do I need to admit or discharge? You admit this patient in the cardiology care for further evaluation if any one of this following is present. If he is a known case of congestive heart failure, if the hematocrit value is less than 30, or ECG or cardiac monitor shows any non-specific abnormalities, also you'll admit, or the patient is had a history of shortness of breath, then he lost his consciousness. If at any point of time the recorded blood pressure in the stay of the emergency department was less than 90, you need to admit this patient. This can be remembered with a mnemonic known as CHESS. C stands for congestive heart failure, H stands for hematocrit value, E stands for ECG changes, S stands for shortness of breath, another S stands for systolic blood pressure being less than 90. Now we'll be seeing causes for sudden cardiac death. Or basically what we are seeing, cardiomyopathy is what we are seeing. Okay, this can hold good for a syncope. Initially, it is a syncope. Sometimes it can be a cardiac death. Syncope, most of the time in cardiomyopathy, syncope is because the patient had an VT or an VF. That's why he had a syncope and it reverted back to the normal sinus rhythm. That's why he gained his consciousness. Sometimes this VT and VF can go into an asystole and this patient can die. Okay, lucky patients present to the emergency department. The first thing what we are seeing is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is also known as HOCM, is the short form, what they call it. Same thing, it means hypertrophic obstructive cardiomyopathy. Some people call it HOCM, some people call it. What happens is there is an enlargement of the septum. Whenever there is an enlargement of the septum, during the cardiac output, this wall, there is the mitral wall, gets closer to the septum and it blocks the entry of the blood into the aorta at all. So no blood enters into the aorta, which causes a syncope, or basically the loss of consciousness because no blood is entering into the aorta at all. And that will result in trigger of an VT or VF. Because of this, there will be a harsh murmur if some blood is going through this. In a relaxed state, if some blood is in rest, some blood will be passing through this to the aorta. Because this is a narrow space, a murmur will appear. It will be a systolic murmur because when the heart is pumping, the blood moves through this and you have a murmur. That's why it is a harsh systolic murmur what this patient will be happening. This is one of the commonest cardiomyopathies. Okay, and it is at risk for VT and VF, ventricular tachycardia and ventricular fibrillations, they will be at risk for. What they do it, if it is a young patient, they remove this enlarged part what is present, so surgical repair will be done. If it's an old patient, ICD implantation will be done, which is a rare thing. So usually surgical intervention is be the preferred one. How do they present? I was quite healthy individual, around 20, 25 years old. He was playing a sport and suddenly he lost his consciousness and he is presented to the emergency department. Currently is asymptomatic. This is the typical presentation what you are having, and you get an ECG done and you see this typical ECG. In the ECG, the main thing what you need to pick it up is the dagger waves, dagger Q waves or deep Q waves. What is a Q wave? Q wave we have learned in the ECG chapter that first negative deflection after an P wave is known as Q wave. First negative deflection. So this is the Q wave. Deep Q waves are seen in inferolateral walls. Mainly in most of the time, it's the inferior wall. See, this is the P wave. This is the first deflection what you're having. You can see there are quite deep, almost one large box it is. We usually do not see so deep Q waves. You can see in the lead 3 also, you can see in the AVF also. You can appreciate in V6 also, you can appreciate in V5 also. In this deep Q waves are also known as dragger waves or dragger-like Q waves, we call it. On an echo, there is a thickening. This is the thickening what you are seeing. This thickening is seen here also. This is the four-chamber view what you are having. This parasternal axis short axis view what you are having. This is also a parasternal short axis view what you are having. This is an parasternal long axis view what you are having. And this is the left ventricle what you are seeing. It is quite thickened. So shouldn't be a problem to pick it up on an echo if an echo image is given. Remember that any structural heart disease is present, structurally abnormal. For example, congenital heart disease like an VSD, ASD is present, or an hypertrophy is present like this. Echo scan is the best one to pick it up. Arrhythmogenic right ventricular cardiomyopathy. What happens in this? Fat gets deposited in the right ventricle. That's why it is known as right ventricular cardiomyopathy. Whenever this fat gets deposited, this can act as a trigger agent for the electrical activity. So it can generate the electrical activity there and resulting in arrhythmias. Most of the time it will be in VT and VF arrhythmias it can trigger. This is a continuing disorder. So initially what they thought is whenever the patient is having these symptoms, we'll do radio frequency ablation and burn that fat deposit what is there. Later on, what they found out is if we can burn it, but the fat deposit again recurs. This is a continuing disorder which is present. Okay, so the fat deposit can recur back. So how many times you will be doing a radio frequency ablation? You cannot do frequent radio frequency ablation. Sometimes unknowingly there might be some fat deposit and that might be a life-threatening event resulting in VT, and asystole and resulting in death. For that reason, this is not preferred in a symptomatic patient. Implantable cardiodefibrillators are preferred. These are small subcutaneous defibrillators. Whenever it picks up an VT or VF, it shocks. Asymptomatic patients are usually treated with antiarrhythmic drugs. There is an ECG. Do we see any typical pattern in the ECG? Yes, a typical pattern is seen in the ECG. That is the end of the QRS complex, you see a notch. This is known as epsilon notch. Okay, you can see in this ECG, epsilon, 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 epsilon notch, which is specific for arrhythmogenic right ventricular cardiomyopathy. This was again tested in an FRCM exam, which has not appeared in MRCM exam, can appear in your exams. Be aware of it. Dilated cardiomyopathy. Dilated, as the name suggests, the ventricles will be dilated. These ventricles are quite much dilated compared to the normal heart what you are having. What is the typical presentation? This typical presentation will be an alcoholic, a binge chronic alcoholic. He might start drinking at 20 years. He has presented at 30 years with a heart failure. A heart failure in a 30 years age in individuals who doesn't have any risk factors. Why is having a heart failure? It is because of dilated cardiomyopathy. So most of the time it is seen particularly in alcoholics. They present with an heart failure. So you're treating the heart failure what they are presented with and referring to the cardiologist. Are there any specific ECG changes? Yes. Both sides of the hearts are enlarged. So LVH, left ventricular hypertrophy and right ventricular hypertrophy changes are seen in these individuals. Left ventricular hypertrophy, we know we will be using an voltage criteria to diagnose it. So more than 7 large boxes, if you compare V2 and V6 here, it will be more than, if you count it here, 1, 2, 3, 4, 5, 6, 7. Already 7 is here, plus 1 if you consider it is 8 boxes. So more than 35 millivolts it is present. So voltage criteria is satisfied for left ventricular hypertrophy. What about right ventricular hypertrophy? Right ventricular hypertrophy, you usually see a right axis deviation where 1 is negative and 3 is positive. That means the QRS complex of 1 is facing towards the QRS complex of 3, which is present here. So both right axis deviation and voltage criteria for left ventricular hypertrophy will be present in this individual. But it is not very specific changes. You cannot label this as a dilated cardiomyopathy. Echo scan will be definitely required in this patient to really label them. So on an echo scan, you can see large, enlarged ventricle. It is not thickened, but it is enlarged. What do you need to? So it is not thickening what we are talking about. It is the dilatation. It is the enlargement of the ventricles what we are talking about. Restricted cardiomyopathy. What happens in restricted cardiomyopathy? In restricted, it is restricted. It has become stiff. The musculature itself has become so stiff that it is not able to contract at all. Why the stiffness has come in? Stiffness has come in because of the deposits of the amino acids. It might be, or iron might be. Hemochromatosis, iron gets deposited in the hard musculature. Sarcoidosis, amyloidosis, amino acids gets deposited into the heart musculature, which will result in stiffening and rigidity. It cannot literally contract at all. Complete contraction of the heart is lost in these conditions. So what you will be doing here is you're just treating the underlying cause here. You cannot do much for the restricted cardiomyopathy. Treat the underlying cause. For example, hemochromatosis, treat the hemochromatosis. So you will be referring to the gastroenterologist. He'll take care of the hemochromatosis. Similarly, sarcoidosis, amyloidosis, similar super specialists you will be referring to, they will be taking care of it. Long QT interval. Okay, long QT interval, there are various causes for long QT interval. It can be inherited because of some congenital abnormalities. It can be acquired. The important thing for you is the acquired thing. If it is inherited, they would have diagnosed at a very early stage. You would have been a known case of QT prolongation. Because of Romano-Ward syndrome, I am having it. Jeverlo-Lyon-Linson syndrome, I am having it. That's why I'm having a chronic PD syndrome. Patient will be giving the history itself. Certain conditions can cause it. That means it can be acquired. What can be acquired, especially the electrolyte abnormalities? Hypokalemia, hypocalcemia, hypomagnesemia, all are reduced. Potassium at the lower side, calcium at the lower side, magnesium at the lower side. Less hypothyroid, less hypothermia. So everything is less, easier to remember. Hypothermia, hypothyroidism, hypokalemia, hypocalcemia, hypomagnesemia. So repeat it 3 times, you will remember it. Everything is hypo. Along with it, certain drugs are very important. What you need to remember? The drugs, what you need to remember is tricyclic antidepressants. Very important. Macrolides, especially erythromycin. This became very famous during the COVID time. COVID time, they said taking erythromycin might be helpful in treating the COVID. They started giving to the elderly persons. It resulted in QT prolongation, resulted in VTVF because QT prolongation, especially predisposed to torsades also known as polymorphic ventricular tachycardias, and resulted in multiple deaths at that point of time. That's why it became very famous during the COVID time. Phenytoin. Phenytoin, again, it's very important. It causes QT prolongation. How do you need to clinically correlate here? Tricyclic antidepressants can present within seizures. Whenever they present within seizures, overdose I'm talking about, tricyclic antidepressant overdose, they can present within seizures. If they present within seizures, you cannot treat with an phenytoin because this drug causes QT prolongation. This drug also causes QT prolongation. You might treat the seizures, but you will definitely cause the QT prolongation resulting in an arrhythmia. So you cannot use an phenytoin. So phenytoin is contraindicated for that particular reason. Previously tested in an FRCM exam. Difficult question. That's why I'm telling FRCM exams what they have tested here. That's why you need to remember in that way to correlate. Any antiarrhythmic, especially class 1A and class 3, can trigger NQT prolongation. Intracranial hemorrhages can trigger NQT prolongation. Short QT interval mainly seen in hypercalcemia. There are various other causes for sudden deaths or than syncope, like in Brugada syndrome, WPW syndrome, LGL. WPW syndrome and LGL causes an SVT or an AF, which results so supraventricular. Brugada, VT or VF. Till now, what we have learned about most of the time will causes VT or VF. Prolonged QT interval or prolonged QT syndromes causes polymorphic VT, torsades. So summary of an syncope and ECG has been given in this tabular form. This is basically summarizing everything what we have learned from the previous class and this class so that everything is at one place. For when you are revising before the exam, it becomes easier for you. So what do you need to remember? Whenever in exam, a question comes on syncope and they have given an ECG, these are the differential diagnosis. First, look at if the heart rate is on the lower side. If the heart rate is on the lower side, one of the blocks. It can be a complete heart block or complete trifascicular block, bifascicular blocks you'll be having. No, looks like a normal what you're having. Then look for deep Q waves are present. Then it is an Hockham. Or arrhythmogenic right ventricular hypertrophy, if epsilon wave is present. Long QT interval, we know how to see the QT interval previous class. Look at for Brugada syndrome, ST segment elevation, especially from V1 to V3, especially in two leads, what you need to look for. WPW syndrome is the delta wave along with short PR interval. LGL, only short PR interval, no delta wave will be present. Along with it, the treatments also I have placed here, so you can revise easily and go for the exam. Before I go into the murmurs, I'll just take up the questions if any questions are there. If heart, if atrial fibrillation for heart failure, decoxin is preferred, but is it related to any duration? No, no. Okay, no questions are present. We'll enter into the murmurs without wasting any of your time. Murmurs. Either you can by heart the things what is given in this tabular form, or use logical way to remember the murmurs. Either ways, if you remember the murmurs, it is helpful for you to answer the questions. So you will be knowing what the lesion, what you are having it. Accordingly, you can make up a diagnosis, and it will be helpful to answer the stem of the question what they are given. Okay, so how to deal with the murmurs? What you need to deal is wherever the flow of the blood is, murmur will be in that duration of the cardiac cycle. Okay, so whether it is a diastolic murmur, whether it is a systolic murmur, will be appearing at that duration. One more thing what you need to remember is if the wall is stiffened, we call it as a stiff wall. If it is stenosed, stenosed means some calcium deposits are there. It has become hard. So it is not able to open it properly. So a lot of pressure is required to open the wall. So it takes little bit more duration. So most of the time it will be mid systolic or mid diastolic murmurs, or it is best heard during mid systole or mid diastole, depending on which wall is involved. Regurgitations, this wall is not able to close properly, then we call it as a regurgitation what we are having. So backflow of the blood is seen. So whenever there is a black flow of the blood during that time of the cardiac cycle, you will be hearing the murmur. So to break it down, first we'll be seeing the murmurs involving the mitral wall and the tricuspid wall what we are having. So we will imagine there is a stenosis of mitral stenosis or a tricuspid stenosis. So the blood, the atria should contract so the pressure increases and blood moves through this stiffened wall what is present. So it will, when the atria contracts during the diastole of the ventricles. So basically this is the diastole of the cardiac cycle. So atria contract during the diastole, and during the mid cycle, the blood will flow. So mid diastolic murmurs are basically mitral stenosis and tricuspid stenosis. Then we'll make it floppy. There is a regurgitation. Okay, so blood is flowing backwards. The wall is not closing properly. What will happen if the wall is not closing properly? What will happen? During the systole of the ventricles, these walls are not closed properly. Some blood will go into the pulmonary artery or the aorta, depending on which ventricle, and some will enter into the atria. So this one will enter because it is not closed properly itself. This is seen in this is seen throughout the cycle, and this is seen during the systole, because when the ventricles contract, it is known as systole. So it is known as pan-systolic murmur. Along with it, you have another murmur known as VST, which is also a pan-systolic murmur. So whenever I say a pan-systolic murmur, three things should come in your mind: mitral regurgitation, tricuspid regurgitation, and VST. So it should be in that manner. Whenever I wake you from your sleep and I ask you pan-systolic murmur, MR, TR, VST should come in. Then we are seeing about mid-systolic murmur. What is mid-systolic murmurs? These are basically the aortic, I have drawn wrongly. Let me rectify it. These are basically for the pulmonary and the aortic wall. Imagine if it is stiff. So blood has to pump against the stiffened wall. So it will be mid-systolic murmurs. Both aortic stenosis and pulmonary stenosis are mid-systolic murmurs. Remember that aortic stenosis radiates to the neck. Mitral regurgitation will radiate to the axilla. In HOCM also, as we discussed, it is a systolic murmur what we are having. Early diastolic murmur, because the aortic walls are floppy, it are not closing properly. Blood has moved in here during the systole. During the diastole, when the pressure of the ventricle decreases, retrogradely they come back into the ventricles. So during the diastole, so this is an early diastole. Early itself, when the pressure drastically falls down, it will start coming in because the walls are not closed properly. So aortic regurgitation and pulmonary regurgitation are seen in early diastolic murmur. What are continuous murmur? The murmur which is heard continuously throughout the cardiac cycle are PDA, patent ductus arteriosus, and fistulas, especially man-made fistulas for diabetes, sorry, for dialysis, not diabetes, dialysis. Fistulas are made between the vein and the artery so that you can easily do an dialysis in those patients. So fistulas and some fistulas can be naturally also, those are continuous murmurs. PDA and fistulas have continuous murmurs. Right-sided murmurs are best heard during a deep breath and leaning forward. Left-sided murmurs are best heard on expiration. And mitral stenosis, you need to remember if the patient is in left lateral position, they hear it much better. So left-sided murmurs during expiration. So take a deep breath, expire out, hold your breath. Then left-sided murmur, that is aortic and mitral wall murmurs are best heard during expiration. Right-sided murmurs, take a deep breath and hold it and lean forward. So at this point of time, tricuspid and pulmonary wall murmurs are best heard. If you're suspecting a mitral stenosis, ask the patient to go into the left lateral position. At the same point of time, tell him to take a deep breath and expire and hold his breath in expiration. You hear it best. Depending on the areas, also some murmurs are heard better in aortic area. Some murmurs are heard in pulmonary area. Aortic area is second intercostal space. Pulmonary area is, aortic area is second intercostal space on the right side. On the left side is the pulmonary area. On the fourth intercostal space, just adjacent to the sternum, is the tricuspid area. Mitral area is fifth intercostal space, mid-clavicular line. This is not very important because if you ask me, a murmur can be heard in all the areas, but it might be heard best in an aortic area, but doesn't mean that you cannot hear that murmur in the mitral area also, because they are in very close proximity. So if you hear a murmur, there might be a faint murmur which you are hearing in the mitral area, but it might be heard best in the aortic area because it is an aortic stenosis what the patient is having. So you can pick it up. That shouldn't be a problem. So each of the valvular heart diseases which are important from practice point of view and from the exam point of view we'll be discussing now. First one what we are discussing is aortic stenosis. Aortic stenosis classically presents with breathlessness, some amount of chest pain will be there, and on exertion they'll be having a syncope. Most of these individuals will be an elderly individuals, and this aortic stenosis is because of age-related calcium deposits in the wall what has happened, and they will present with an harsh systolic murmur which is best heard in the sorry right second intercostal space. Because the aortic wall is stenosed and the left ventricle has to pump against the resistance of the aortic wall, the right ventricle undergoes an hypertrophy. So on an ECG, left ventricular hypertrophy changes. There's a voltage criteria what we have discussed they will be presenting with. Most of the time they present with an breathlessness, that is nothing but because of the heart failure. So heart failure treatment, diuretics or CPAP, which we'll be learning in the next class, we'll be applying those parameters here. Again, best best modality to diagnose it will be an echo scan, because this LVH changes are non-specific. It is not only specific of aortic stenosis, it can be seen in an hypertensive patient also. Here, what you are seeing here is an stiffened aortic wall, which is not opening as you expect it to open. It is very difficult to pick it up. But this is an aortic wall. This is the aorta, what you are having here. This is the left ventricle, what you are having here. This is not opening. Once it contracts mid-systolically, it is opening here. That's why the murmur is also seen mid-systolic. Aortic regurgitation, incompetence, also known as incompetence. Regurgitation, other name is incompetence. Aortic incompetence, aortic regurgitation, names are one and the same. Mainly seen during aortic dissection. A patient who has an rectosternal chest pain radiating to the back, has a murmur, then you're thinking of an aortic regurgitation. Can be seen in infective endocarditis, can be seen in prosthetic wall dysfunction, soft blowing, early diastolic murmur, as we learned before, it will be, they usually present with an heart failure. So treat the heart failure and refer it. Echo scan will be the diagnostic. There are some named things which can be present. It's an aortic regurgitation. So water hammer pulse, rapid rise and quick collapse of the pulse, which can be seen. Visible carotid pulsation is known as Corrigan's sign. Quicken's pulse is capillary pulsation visible over the fingertips. DeMuscat sign is nodding of the head. Till now, they are not tested. These are difficult to pick it up. It is not an easy science to pick it up. But if they ask anything named, kind of can appear in the exam. That's why I have mentioned it here. Even collapsing pulse can be seen in aortic regurgitation. Collapsing pulse, what happens here? You feel the you feel the radial pulse, and suddenly you raise the hand up and you'll not feel the radial pulse. That is known as collapsing pulse, which is also seen in aortic regurgitation. So Water-Hamel pulse, Corrigan signs, Koenigsegg signs, De Muscat signs, all seen in aortic regurgitation. So named signs or named findings are present in aortic regurgitation. You can remember in that way. Mitral stenosis. Mitral stenosis, typically history will be a pregnant lady who was presented with an heart failure. So pregnant lady who has presented with a heart failure, think of there might be an underlying mitral stenosis. Young, she's 29 years old, pregnant, but presented with an heart failure. So there will be undiagnosed rheumatic heart disease this patient will be having because of pregnancy. Pregnancy, the intravascular volume has increased. The patient has gone into hyperdynamic hyperdynamic state of the circulation. That has resulted in the heart failure. So whenever you auscultate, they'll have an mid diastolic murmur, which is loud as one. That is, first heart sound is loud because first heart sound is produced because of the closure of mitral and tricuspid walls. As the mitral wall is stiffened, it becomes a loud heart sound in this individual. That's how you need to pick it up. Again, treat the heart failure what the patient has presented with, refer to the cardiologist. Echo scan is the diagnostic. No particular ECG changes can be seen. Sometimes a left ventricular hypertrophy can be, uh, sometimes on an echo scan, you can see an left atrial hypertrophy can be seen. And sometimes left atrial hypertrophy can be seen, but ECG changes are nil here. Nothing is specific what you can see for mitral stenosis. Mitral regurgitation, it is one of the complications of myocardial infarction for us from the emergency department. Someone has an ST segment elevation MI, you auscultate him, he has a mitral regurgitation. So whenever a patient is having an MI, auscultate him. There might be involvement of the chordae tympani resulting in rupture of the chordae tendineae, resulting in a mitral regurgitation. So these are the chordae tendineae what you are having, which holds the mitral wall in its place. Rupture of it will cause the floppy wall, or mitral regurgitation will result in. Again, this is an emergency. You need to involve a cardiothoracic surgeon along with the cardiologist. So cardiologist, anyways, you'll be involving for an MI what the patient is having. Along with it, surgeon needs to be involved. Cardiac surgeon needs to be involved. That is the importance. So what is the importance here? Whenever the patient is having an MI, always auscultate and see. They might be having a mitral regurgitation. How's the murmur is heard? It is a pansystolic murmur which radiates into the axilla. Do not forget, pansystolic murmur radiating in the axilla. In a myocardial infarction patient, it is a cardiac emergency. Involve the cardiothoracic surgeon along with the cardiologist. You cannot do much in the emergency department. Anyone has any questions, you can ask me. This is the part 1 of the cardiologist, what we have finished here. Pulmonary edema and systolic blood pressure less than 90 treated with inotropes? Yes. Because pulmonary edema, we are suspecting in an anterior wall myocardial infarction. So we are treating with an inotropes in this patient. We are not giving fluids. So any patient who already has basically pulmonary edema basically suggests us that the patient is in fluid overload. So giving more fluid will be disaster in this patient. So you need to treat these patients by giving inotropes. Some patients, for example, is a fluid overload. This I'm going beyond the scope of MRCM exam. Some patient, for example, a CKD patient, chronic kidney disease, renal failure patient, might go into a fluid overload because he's not urinating much. And he has come with an low blood pressure. Do we still give furosemide? Yes, still we can give the furosemide if you're confident about the fluid overload what this patient is having. He has gone into hypotension because of the fluid overload. Bring down the fluid overload. Furosemide, if you bring down, the blood pressure will increase. This is dependent on the Frank-Sterling curve, what you have learned in your Frank-Sterling curve, what you must have must have learned in your primary classes, where it suggests that till certain point of time, fluid will help to increase, but again, it starts falling down. So this patient is here in the curve. So reduce the fluid. So the ejection fraction will increase. The systolic ejection fraction will increase if you reduce it. That's the idea behind giving furosemide in those patients. There's one more patient, EKG patient, the right ventricular infarction and posterior wall findings. Again, what you are seeing here is there will be an inferior wall myocardial infarction where we'll be seeing the ST segment elevation. 2, 3 AVF, you will be seeing an ST segment elevation. Next thing what you want to do is there an ST segment depression in V1, V2 and V3? If present, then it is an posterior wall myocardial infarction. If not present, get an right side at V4. Yes, ST segment elevation is present in right side at V4, then you consider as a right side involvement. That is right ventricle mainly we call it, but right atria also gets involved here. Those are the ECG findings in an inferior wall. Basically, you are asking about right ventricular and posterior wall MI. These are the things what you need to remember. ECGs, have a look. I have shown you ECGs, how an posterior wall MI will look, how an right ventricular infarction will look. That will help you to solidify the memory point. Okay, we have covered a lot. Go through the classes, make your own notes, going through the class and using your blueprint, what we have provided. Start solving the questions what we are having, because majority of the questions have already been from this what we have covered. So we will be going through the recall questions in the next class, including the last dead recall questions will be discussed in the next class. And it will be, it's already been uploaded in the next class. Next schedule when will be provided for next month schedule, today we will be providing. Okay, and after this class in next few hours I will be providing you the next schedule. Okay, will not be delaying. Today it is already ready, we'll be providing you. So I'm not seeing any questions coming up. Thank you everyone, we'll end the class here. Thank you everyone.